Hello. Mic test 1, 2, 3. Hello. 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 Oh. అది నిన్న చేసుకుని కోళ్ళకి వేసుకున్నాను నెక్స్ట్ యూజ్లో కొన్నాను. అప్పుడు నేను ఇంకోటి ఏంటంటే ఇది రివర్సల్ కేబుల్ ఉంటుంది, జూమ్ లెక్క రివర్సల్ కేబుల్ ఉంటుంది కదా, ఆ రివర్సల్ కేబుల్ ఆ ఛానల్ పెట్టి ఆ ఛానల్ వచ్చేసి అది రివర్స్ చేసినా
Sir, we'll start in another 5-10 minutes as no that's one. Meanwhile, we can discuss one topic, sir, and then in between for our sake, if everyone are free. Of this, sir. Yeah, because they're basically making a large scale. That's how the whole thing format is changed. Earlier, individual people are coordinating with maybe anatomy department, I'm coordinating with department.
Now they made a separate department which they made. So it will all settle by the same. Always anatomists. And they should have a bigger role. Because ultimately they are the only one who will cut out the. You can do everything. You can arrange everything, but who will be cut out for you? They have to. I mean, I feel most centers in the have a bigger say in it and they have control. Of course, you know, run it, but they have a bigger role of the same. Yeah, you can see it's what of which is like we got this anterior Skullbase as well as lateral Skullbase. Like maybe we had Skullbase. The whole cadaver is born by the corpus. I mean, we pay for it. So we now we pack that. Now we will same cadaver Skullbase. And I'm going to same cadaver for complex brain now. So it's easy. Because I want a cadaver. So I'm using it whenever I want. Department which is tell me never basically the 20,000 is also being charged because of the AC and cooler maintain that. I don't think no.
Good morning. Then when has come. Huh? Okay. Good morning to the second day of the session. And so today we'll again have some few lectures on how I do it, of different approaches, and then followed by we'll have a cadaver dissection demonstration and hands-on on transorbital approach. The first talk is by Dr. Nishant from NIMHANS, Bangalore, and he'll be speaking on endoscopic excision of orbital lesion.
Thank you. Good morning, everyone. Thanks, Dr. Ramesh and the rest of the organizing team for inviting me and having this workshop. I'll be talking on a case which I operated, endoscopic endonasal excision of intraorbital schwannoma. This before going to lesions of orbit, we have to know the intraconal and intraorbital anatomy. When we go towards posteriorly near the proximal part of orbital apex or near the where it enters intracranially, we have to make sure that the anatomy of superior orbital fissure and the rest of the annulus of Zinn and the cone has to be understood. And more importantly, we have to make sure that we know that a lot of nerves are crowded in that area, but which is not the case when we come more anteriorly, where a lot of fat is there and a lot of room is there for surgery. If we see the other picture, we can see here that whatever is medial to the optic nerve and inferior to the optic nerve are easily approached. And more importantly, we have to know that when lesions grow in that part, like usually they occupy both superiorly and inferiorly. So these are the cases which are ideally suited for endoscopic excision. So this is taken from Roton when we separate the superior rectus and medial rectus. This is how we see it. More importantly, there is infralateral arterial trunk. This actually a lot of people from ophthalmology, they tend to divide these cases according to the location of the lesions in these quadrants. More importantly, it is done for cavernous sinus hemangioma, which can be extrapolated to all the intraconal lesions. So in this case, we have to know that though we tell that only medially located tumors are ideal, this is the angle of approach in which we operate from the other contralateral nasal aperture. This is the angle of approach. So except the quadrant where marked in red, almost all locations can be accessed medially, provided we do careful dissection and we take care of the anatomy and we know where the optic nerve is and we know where the other branches of intraconal nerves are. So this, I'll go directly to the video. So this patient is a 22-year-old guy who had a proptosis. Vision was normal. He had a bad proptosis, which has progressed since almost 2 years. And this is how the imaging looked like. The lesion was medially located. It had all the features of a schwannoma. More importantly, we have to know that it was quite large and going very anterior. So if we are trying to operate this patient endoscopically, we have to understand that the more anterior part, it is difficult to access. So we had approached oculoplastic surgeon. The plan was to do medial caruncular approach and push the tumor more posteriorly when we try to remove it endoscopically through the nose. So that was kept as a backup only if this could not be mobilized. So that was the plan. So we went ahead and did. This is another illustration where different approaches for intraorbital. This is a general picture and it's not a mandatory or it's not a guideline. So it can be operated in any way, but usually If it is medially located, we tend to operate endoscopically. Lateral orbitotomy for laterally located intraconal lesions. And superiorly, if it is located, like more commonly, people do craniotomy in the recent past. So we did the unilateral middle turbinectomy to reach more superiorly. And we harvested a flap on ipsilateral side. And on the contralateral side, we elevated a small flap so that we get a adequate access from the opposite side, because the approach has to be from the opposite side. This is where we did access from the opposite side. We use navigation system to exactly localize which is the most superior part and which is the most inferior part we have to expose. We did debridement of superior posterior ethmoidal sinuses so that we get optimum exposure. Lamina peperacea can be easily dissected. It's not a great part, not a very difficult procedure. And anteriorly, a vertical incision, posteriorly, a horizontal incision is done. And after that, you can see the fat is protruding because of the lot of pressure inside the cone. And this is the medial rectus, which has to be retracted inferiorly. And in this case, the optimum corridor was between the superior rectus and the medial rectus. Though some cases it depends on the quadrant in which it is surfacing, and we have to choose that. It is hard for anybody who has experience in operating orbital tumors, intraorbital tumors. It is a juggle because a lot of fat will be there. A lot of blind dissection had to be done. So we have to use a ball dissector to dissect all around, like how much ever is possible initially, and then we do an incision. And it is just like any schwannoma surgery. We have to do intraorbital, the intralesional decompression, because it's quite a large tumor. Initially, we can't do pushing and pulling. Like we tried various instruments to decompress it. Ultimately, some middle part of the tumor had to be decompressed with debrider. So we knew that we have to be more careful. I don't recommend using debrider for all the cases, but still some cases like after devascularization, meningiomas, as well as schwannomas, we can use debrider because relatively avascular. And this controlled traction had to be put. There is no other way. You had to put traction like any other endoscopic surgery. We had to have traction if it is quite distant. Controlled traction has to be done. Like we were very mindful. This is the anterior part. We thought that it may not come actually, while after retraction, anterior part got delivered through this approach only after adequate decompression. So adequate decompression helped us in decompressing this tumor. So this debridement, you can see this debrider I have used only after the lesion is delivered into the nose. So that has to be taken care. And after some time, you have to do some blind dissection and see whether any residual is there. And it was very easy to see the capsule all around, and it was easily dissected all around. The most important thing was like the optic nerve was located more medially and superiorly. That is the part where we have to be careful. So hemostasis reconstruction, nothing fantastic. Like because like a lot of people do reconstruction of the medial orbital wall, we have to understand that if we have operated on a small tumor and there is a lot of fat, that is a case where orbital contents can move out and can cause sinking of the eye. But if we don't remove the inferomedial crest of the orbit, it is very less likely that the herniation of the fat happens medially. I will show that. So we did a standard reconstruction, replaced the mucosa, and the opposite side also that we had elevated a small flap, but we replaced it back. So putting of the nasal packs in standard fashion. This is the immediate post-operative photo. We can see that there is some chemosis. This is the preoperative, and this is the post-operative photos of this patient. We have to understand that because of some traction, patient may have medial rectus paresis in the initial part, which he had initially, but over 6 months, all extraocular movements were normal. So there are so many ways in which these tumors can be operated. One of the recent in the recent past, people have opted for endoscopic surgery, and it's a fantastic way to remove tumors which has a specific indication. So the important part in this, especially to avoid complication, is to have to preserve the intromedial strut. That means even the orbital contents want to herniate, it has to herniate only medially. It will not cause any problem. If the inferior part is removed because of gravity and traction, it can herniate and cause anophthalmos. So flap may not be according to even people who have extensive experience. They tell that flap has to be taken only SOS if you suspect herniation, and in which case we have to have rigid reconstruction as well. And orbital fat dissection is one critical part where people who have operated orbital tumors may know that it will take some time to find the tumor inside the fat. So it is the same with operating endoscopically as well. Control traction has to be put. Some patients has to be there to dissect all around before putting this optimal control traction. Thank you.
Questions? We'll have questions later. Thank you, Dr. Nishant, for presenting a beautiful video and telling the nuances of operating on an orbital tumor. The next paper is by Dr. Vishwanath from Yasoda Hospital, Secunderabad, and he'll be speaking on role of neuroanesthetist in endoscopic skull-base surgery.
Good morning, everyone. My topic is of role of neuroanesthesiologist. Role of neuroanesthesiologist in endoscopic skull-base surgeries. As we know that the goals are of always of airway management is always the airway management is always the primary concern in anesthesia. So careful planning is required and execution of the airway management is crucial, followed by hemodynamic stability. As we all know that providing a still and bloodless surgical fluid to facilitate good surgical exposure is mandatory in any skull-based surgeries. And recently, as there is an inherent risk for critical neurovascular structures, including the various cranial nerves and the great vessels injury, and their neurological sequelae may be prevented by using the intraoperative neurophysiological monitoring. And as we all know that these surgeries are performed in sitting position, semilateral position. And in these cases, if the patient strains or bucks during the surgery, it will be devastating for the patient. So to avoid this, we have to use the depth of monitoring. The patient should be deep. Otherwise, the patient may move and the patient can suffer devastating injuries. And fluid management, careful fluid administration is always required to prevent hypo or hyperolemia, which can impact surgical exposure. And finally, the emergence facilitating early recovery for prompt neurological assessment is required. So intraoperative challenges, what are the challenges that we as anesthesiologists face are the first is patient positioning. The patient positioning, the sitting position usually requires as we can see, this is a steep sitting position. Patient's neck is flexed, so we want a flexometallic tube, and in these patients, and the patient's airway. The patient is usually positioned with his or her airway from away from the anesthesiologist, and we are situated down there, and the patient is here. So it's very difficult for us to access the airway, to access the intravenous and intra-arterial catheters that are being placed. So we need longer circuits and intravascular, intravenous extensions are required. And securing the ET tube, because in between the surgery, we cannot access the patient. So securing the ET tube is a primary concern for us. So as we can see, the surgeon is performing here and we are sitting way away from the patient. So we need longer circuits. So as you can see, I have kept a pic. This is a long circuit which is being used with by us, and it's away from the surgeon. So in hemodynamic monitoring, we always are concerned about the neurological concerns are there. So recently we are monitoring MEPs, SSCPs, VEPs, visual potentials, BERA, and neurologically we are using this intraoperative neurophysiological monitoring. And cardiovascular, we are monitoring the invasive. Always we prefer invasive arterial lines to measure the invasive blood pressure. And the renal, we are always worried about the urine output. So we have to continuously check about the renal output. And maintaining normothermia is always a primary concern, as it affects adversely on the brain as well as on the other organs. Intraoperative, when we come on to skull-base anatomy, thorough understanding of the complex skull-base anatomy is required for us also, as because we need to anticipate and navigate the potential challenges. These patients usually present with electrolyte imbalances. So vigilant monitoring and correction of electrolyte pre-operatively is required in these patients before taking into the OT. And cerebral edema may be seen, and the recognition of this edema and treatment of cerebral edema to prevent the increased intracranial pressure is mandatory. And the careful management of blood loss and prompt intervention is required. So coming on to intraoperative neuromonitoring, in all the skull-base surgeries, because the patient is having a there is always a chance that patient may suffer nerve injury. We are always concerned that patient should be monitored intraoperatively. Therefore, we are trying to always monitor the nerves. And recently, we are using remifentanil infusions along with the propofol infusion. Previously, to prevent any bloodless surgical field, to get the bloodless surgical field, we used to use dexmedetomidine, which used to cause hypotension as well as bradycardia. But recently, we are using remifentanil. The remifentanil infusion is very good in the sense that it is providing both hypotension, bradycardia, as well as we are getting the patient is tolerating tube very well. The tube tolerance is very good with remifentanil as compared to dexmedetomidine. And lastly, the emergence of anesthesia. One of the anesthetic goals during endoscopic skull-base surgery is to achieve a smooth emergence, as straining and cuffing during emergence may lead to venous bleeding and CSF leak also from the nasal cavity or the dura, which has been closed. So to avoid that, we need the patient to be a smooth recovery should be there. And the patient, usually surgeons prefer spinopalatal ganglion blocks for pain control. And at the end of the surgery, throat pack removal and suction should be done. And we always prefer the patient to be awake during extubation, because we want the patient to be awake so that the nasal thing is blocked. So we want the patient to be awake. Otherwise, the patients may have obstructive sleep apnea. Patients will have this tongue fall will be there, and the patient will have desaturation. So to prevent that, we want the patient to be fully awake during the extubation. And in post-operative care, pain management is there. We use a multimodal analgesia control, where we'll provide the patient with opioids. We'll give spinopalatal ganglion blocks bilaterally, and respiratory support is given to the patients if and when required. And neurological assessment is more required here. The vigilant assessment of the patient's neurological status, both intraoperatively and postoperatively, is required. And these patients who undergo pituitary surgeries may develop diabetes insipidus, and the patient's urine output should always be monitored in these patients. To conclude, that the challenges presented by these surgeries, including providing a relatively bloodless surgical field and getting the patient for intraoperative neurophysiological monitoring, is challenging for us. Nonetheless, fastidious planning, meticulous intraoperative management, and thorough postoperative care are important to yield good results and prevent complications in this surgery. Thank you.
Thank you, Dr. Vishnath. We will take up the questions in the last. The next speaker is Dr. Narsingh Rao, and he will present the role of tuberculum celli drilling in pituitary adenoma.
Very good morning, everyone. First of all, let me congratulate Dr. Ramesh for wonderful meeting, good scientific session, and nice hospitality. Thank him for giving the opportunity to present my experience in, or my point of trans-tubercular drilling during in pituitary adenoma surgeries. It's a well-established fact that pituitary adenoma surgeries, endoscopy is the choice of approach. It is a well-established fact that if you want to remove pituitary, now it is endoscopy. Endoscopic approach is best. But generally, what happens in the pituitary adenoma is that you drill only sella and you do not want to touch any other structures. That is what is classically described. Although some people go and expose the cavernous sinus and both sides and up to the clivus on inferiorly, nobody would usually touch the tuberculum sella. However, we know that tuberculum cellar drilling is an established approach for tuberculum cellar meningiomas, but not for pituitary adenomas. So what are the factors which influence the total excision of the pituitary adenoma, or you want to have good decompression of pituitary adenoma? What are the factors which influence, which we all know? Most of the times it is the consistency. If the tumor is soft, it will come off nicely without any problem. And you don't have to do some extra circus there and the tumor will beat out. And second point is the configuration. If there is a supracellular extension, more the supracellular extension, more difficult will be your tumor and you will not be able to remove the tumor totally out. And of course, type of the cellular enlargement, how the sphenoid is aerated, all these factors and size, we all know that they are the factors which influence our total excision of the tumor. Now let us see few points on configuration. If you have a tumor like this is a beautiful tumor with small supracellular extension and an extensively aerated sphenoid sinus, wonderful to remove. Go there, just drill out this cella, it will come off nicely, no problems. Suppose you have a configuration like this. This is supracellular extension is a little higher. It is above the level of the cella. A significant supracellular extension is there, but the sphenoid sinus is good enough, so we can as well remove it in a better way with some dissection. If the tumor consistency is soft, you can remove. How about this tumor? This is a large tumor. You know that it is having supracellular extension and almost into the third ventricle and a small precellular type of sphenoid sinus. You get into problems. So this is what is the important concept for all of us to understand, that the endoscope direction is this, and you will be able to remove only this bit of the tumor, or the exposure you are seeing. What you are seeing is only this particular part of the tumor, and this portion is always left behind. If this tumor consistency is soft, it will come down and you will be able to get away. But as your experience grows, you understand that this is the portion which is important, and it always remains like a hood. If you see, we are drilling on the cella, and if you are leaving this part doesn't get exposed. That's the usual skull base concept. Each millimeter of the bone will give a panoramic exposure with endoscope. We all know this. So what you do not want to see in your post-op scan is that hood, which always remains, and it is so nasty to see. You yourself feel bad that I have done the surgery, but still the tumor is remaining. So endoscopic trans-tubercular approach is described for meningiomas. We can as well utilize them for pituitary adenomas, not fully, but you can make use of tubercular drilling. So that's what's the concept which I'm trying to present in this. So there are certain nuances which you have to know when you are doing this trans-tubercular approach. Your positioning has to be good. I use navigation for all the cases whenever it is feasible. The important thing what I observed is that when you position, you have to use navigation twice. Your positioning should be done with the navigation, and you see what is the extent you are drilling and is it accessible to you freely or not. Then if you have to move, you have to re-register the coordinates or navigation points, because after repositioning, if you are confirming the exposure when you are the area which you want to see, you can navigate again. And the second point is that, of course, vascularized nasoseptal flap with the advent of with the cooperation from the ENT surgeons, it is a norm now, and it is most important. And because you are drilling tuberculum, you have to have a longer flap, and which has to be planned. Another thing is widest sphenoidotomy, which is required for the case. And posterior ethmoidotomies, it is sometimes people do, sometimes people don't do, but I generally prefer to do bilateral posterior ethmoidectomies, particularly if you are using binostril technique with a four hands technique. It is always nice to see the things properly and don't be worried about, wow, we are removing the ethmoids. The only thing is that sometimes anosmia can happen, but that's fine. You should have the total excision. That should be your goal. The second thing is that drilling of, there are anatomical landmarks which are important. MOCR, LOCR, that is lateral opticocarotid recess, medial optical carotid recess, which we have to expose properly. And you should have a bilateral cavernous sinus exposure thoroughly, and there should be no compromise on that. A good understanding of anatomy, both intracranially and extracranially. This is an exercise which every neurosurgeon has to do, because we are all used to the transcranial anatomy. I think when I started my career in pituitary adenomas, we were doing only transcranial approaches, as last time Dr. Manas also pointed out, that we should have a thorough understanding of intracranial anatomy first, how it looks from the inside. This is the anatomy. You will have optic nerves here, tuberculum, sella here, the sella here. All these things we know by reflex, but endoscopically when it comes, we don't know what is going to be here. So these points which you have to continuously analyze, intracranial versus extracranial, endoscopic versus the intracranial, then we'll have a correct concept. Here you see, this is the optic canal which you see. When you see an optic nerve here, immediately below will be your optic strut. I'm sure I'm able to point out with my this thing. This is the optic strut. And when you want to drill here, your optic, the ICA is very close by. You can use your correct Doppler, but still your drilling should be very careful in order to avoid any inadvertent injuries to the ICA. This is a small video. We want to show, this is the sphenoidotomy, early sphenoidotomy. This is the cellar drilling, a short video, the cellar opening, face of the cellar opening. This is the tuberculum. And you have nice, of course, this is a well aerated sphenoid sinus. You have the lateral optic recess here. And this is the portion which you have to drill thoroughly in order to really expose your carotids. Of course, this is towards the clivus. This cellar portion nicely up to the clivus, you have to remove and expose both bilateral carotid arteries. If you have a Doppler, you can use it. This is the anatomy which you should have a correct understanding. I think just I wanted to show this. Oh, it's okay. It's moving out. So this is the anatomy which everybody should remember. And this is the dural opening. In this, tumor is not soft. The second video I'll show that the tumor has to be removed like piecemeal, and it will have a capsule. And not all tumors are like this, but sometimes when you encounter these kind of tumors, you have to be very careful. You have to have a good exposure and also dissect like microscopic dissection. The tumor coming out, and still the portion, small arachnoid bulge was there. I had put a cottonoid, and when I removed, I could see the arachnoid bulge out there. So this is the excision which you get. I'll end up with a small another video. This is of course a good amount of apoplexy is there, not required, but it had a small cellar. The sphenoid was wide, but the septum was oblique, and the precellar type of sphenoid sinus was there. So I didn't take risk. I just went ahead with the tubercular drilling. So this is the drilling. The tuberculum. This is the portion which I am trying to remove. Here at the left side, this I'm using the carotid Doppler. Yeah, you can see the both ICAs. You should be able to visualize. I mean, if it is visualized, it is best. Means the total extent of panoramic exposure, you will get it. So this is the total exposure. Of course, in this case, the tumor was having apoplexy. So when I was incising the dura itself, there was ooze from the apoplexy material. The clot had come out, and of course, with the total excision, the tumor could be achieved. So just want to show that this is the area which you have to dissect, and this is the 3D reconstruction to show the tuberculum is drilled totally. So we can make use of the trans-tubercular drilling even in the pituitary adenomas, and it is important that we learn these techniques to achieve our excisions fully. Thank you very much for the attention.
Thank you, Dr. Narsingh Rao, for presenting the role of plenum sphenoidal drilling in pituitary tumors. We'll have questions in the end of the session. The next paper is by Dr. Krishna Tej from Yashoda Hospital. And he will be presenting on interdural pituitary transposition.
Good morning to all the teachers and colleagues. I thank Dr. Ramesh, organizing committee, and NSA for giving me this opportunity. I'm Dr. Krishna Tej Reddy. I'm associate consultant in the Yashoda Hospital Department of Neurosurgery, Secunderabad. So I'd be talking on endoscopic endonasal interdural pituitary transposition. So since it's a 5 minutes topic, like I've concise this as much as I can. So coming to types of pituitary transposition, it's mainly of 3 types: interdural, which can be unilateral or bilateral; intradural, hemi or full transposition; and extradural. So just before getting into the topic, like we just have to know about the endonasal dural anatomy. So this is courtesy of Dr. JFM. So the outer layer is dura is a periosteal layer which continues as the anterior wall of the cavernous sinus, and inner dural layer is the endosteal layer which continues to form the medial wall of the cavernous sinus. And from here we see, so there will be a lot of paracellular ligaments such as superior, inferior, posterior, and the most consistent one being the keratocranial ligament, which forms the medial part of the proximal dural ring. So these arise from the medial wall and go on to attach to anterior wall of the cavernous sinus. They attach to the ICA and keratocranial ligament along with the once it loops around the ICA, it goes on to attaches to the anterocranial process. So we have to keep in mind these ligamentous structures. So so once we get into the cavernous sinus, so we have to carefully dissect off, identify if they are present, and most important being the inferior hypophyseal artery, which arises from the cavernous segment of the ICA, and which is usually most closely associated with the post inferior parietal ligament. And whenever it is present, it has to be identified and coagulated to avoid any postoperative hematoma. Coming to the interdural, so this was initially described by Dr. JFM. This is a relatively new one compared to the other 2. So here we get into the interdural layer. Here we can see, and once incising the one of the outer layer, we'll get into the cavernous sinus, which I'll explain to you in the coming video. And then we'll identify the ligaments, cauterize the inferior hypophyseal artery, and then carefully dissect off the pituitary gland to the opposite side to get access to the dorsum sellae for dorsectomy or posterocranioidectomy. So this is a interdural is a transcavernous route. It necessitates that transection of the inferior hypophyseal artery. So here we transect the IHA proximal, that means near its origin. And this requires all the identification and transection of all the paracellular ligament. And keratocranial ligament can be divided up, and we can reach up to diaphragm to gain additional access into the suprasellar space. So advantage of it being we'll gain access to lateral as well as central portion of the dorsum sellae. It provides an excellent exposure for performing post-cranial by mobilizing the medial wall of the cavernous sinus along with the pituitary gland. It provides access to oculomotor interpedunclar assistance, and whenever required for large lesions, this can be performed bilaterally for large and giant lesions. But the advantage of doing only unilateral being we'll be able to preserve the opposite side IHA, as well as the most important being the venous drainage, because opposite side will be still attached to the medial wall of the cavernous sinus. So indications, it provides optimal surgical access to the posterior crinoids, dorsum sellae, retroinfundular area, for accessing paramedian eccentric lesions such as chordomas, chondrosarcomas, or petroclival meningioma. The video which I'm showing is one of a petroclival meningioma. So where we have to do the, we had to do the posterior clinoidectomy and remove part of the dorsum sellae to gain access. And it can be, so show you the video. So here we are getting into the interdural space. So that leads to the cavernous sinus. So here we are opening up the anterior wall of the cavernous sinus. So here we can see that's the inferior hypophyseal artery, which we are coagulating proximally to its origin. So this is an important step in doing this technique, because this not being able to identify or cauterize it is most common cause of postoperative hematoma. So once we do that, since it's a petroclival meningioma, the bone was little brittle, so that was a little bone pieces coming out. And we further move on to incising the anterior wall and up to keratoclinoid ligament. So in between, we have to use effluent use of flow seals to stop the bleeding from the cavernous sinus. And once that we have done that, then we can carefully dissect off the pituitary towards the opposite side. Next one is intradural. So this was first described by Kasam, Dr. Kasam, and it also can be done as a hemi and full transposition. So this is basically by this we get into the sella without getting into the cavernous sinus, and we'll dissect off the so-called pituitary pseudo ligaments which attach the pituitary gland to the medial wall. And here we ligate and or cauterize and cut the IHA distally away from its origin, where it enters the pituitary gland. And this also can be done as hemi or full, depending upon the need for exposure. Advantage, this provides an excellent rostrocaudal for exposure for retrocellular and retroinfundular areas. For unilateral access, this can be modified to carry out a hemi transposition, as I said, so that it still have venous drainage on the opposite side. No need to get into the cavernous sinus, and it's ideally for the midline intrinsic tumors of pituitary stalk, hypothalamic, optico-hypothalamic region lesions, etc. And last one is extradural subcellular. This is now rarely, seldom we do this. So this was described by Dr. Silver, Theodore Schwartz. So basically, here we'll be elevating the periosteal layer of the bone so that the gland will be pushed up. And here for the additional exposure, if needed, we can remove the tuberculum sellae on the top so that we can push the gland more up a bit. So this gives usually an excellent exposure for the lower part of the dorsum sellae, but reaching the upper part is very cumbersome, and especially the removing posterior clinoids through this approach is very difficult. So, but we don't need to get into cavernous sinus. We don't need for any inferior hypophyseal artery sacrifice, and all the venous drainage all will be preserved. So this is more commonly where dorsectomy is needed to get into the retrocellular and into the prepontine and interpedunclar assistance when the lesions are little low lying. So thank you for your time.
Thank you, Dr. Krishnatej, for finishing in time and having clarity in explaining the different procedures. The next paper is by Dr. Kaushal from Apollo Hospitals, and he'll be speaking on endoscopic CSF leak repair.
Good morning, everybody. Thank you, Dr. Ramesh and Co, for giving me this opportunity to present my work. I'm going to present on endoscopic repair of spontaneous CSF line area, the challenges that we face. So there is always challenge from directly from confirmation of CSF leak till the management. So clinically, the most important thing clinically, patient present with rhinorrhea, the fluid leaking from the nostrils, then we should identify whether it is CSF or any other fluid. Okay, there are many methods, but the most importantly, clinical methods are, that's what we should rely on. Of course, there are other things, but beta-2 transferrin being the more specific test. And then the other part of the story would be the identification of the defect. We use a lot of radiological or imaging modalities to identify the site of leak. The site of leak can be single or multiple. We should always identify and also make sure that we diagnose on the imaging, and also during the surgery, we should make sure that all the defects are repaired. So the most commonly what we rely is always on CNS, PNS, CT, PNS, and as well as MRI, and other tests like CT cysternography, MR cysternography, and neuronuclear scans are the other modalities to identify the CSF leak. Most of the times we do CT, PNS to identify the bony defect, and to see the encephalocele, the MR would be sufficient, and both of them are complementary to each other. I always prefer to always have to identify whether it is a high pressure leak or a low pressure leak, especially when the imaging is suggestive of something like a idiopathic intracranial hypertension feature suggestive of that. And also if you have a partial empty or a complete empty cell kind of features, I would always look for any features of a raised ICP in these patients. And an ophthalmological examination and a fundus examination is also important to differentiate. CSF opening pressure, most of the times I get it done, and also it helps us to rule out any meningitis in these patients. So we know the approaches. It can be an intracranial approach or an extracranial approaches, and what we are doing now is the endoscopic approaches. So I'll be presenting two cases. This is a patient who is about 50 years old, presented with fluid leaking from the right nostril. So if we see that there is a defect here, and on the right side, if you see that the area near the olfactory fossa on the right side, there is a defect there. The lateral lamellar part is also defect, and if you see the ethmoid bullous ethmoidalis area also, you see that there is the aerification is gone, and there's a small defect on the other side also. If you can point it, so that is the area. So there's a CT, and the MRI also shows that. Okay, right side you have a bigger defect, and you see there's a small meningocele on the left side here. So I'll just go to the video directly. I raised a nasoseptal flap on a standby, and after that, so if you see that I can, there's a multiple, so there's a multiple encephaloceles there. The multiple small defects which I identified, removed the turbinate, and if you see there is There's another one here. This is in the right side, right nostril. So I didn't expect preoperatively multiple this thing, but there's another one here laterally after removing the turbinate and the uncinate. And after this is where I'm shrinking the encephalocele. So in this, I took a lot of time to denude everything to create the raw area. I thought since there are multiple defects are there, I should make sure that I shouldn't miss any of the defects before I repair. So we use the suction cautery also. I made sure there is nothing there inside there's no leak there in the sphenoid area. Opposite side also, left side I've approached. Left side also there was a defect which I plugged a fat. I always keep my thigh prepared, and then I take fat as well as the fascia graft if required. In this patient, there are multiple defects. I used all kinds of graft, the mucosal graft, everything I had to use before we enhanced with the fibrin glue. This is another case, is a lady who had right-sided CSF rhinorrhea, and if you see, she had a defect in the sphenoid, lateral wall of the sphenoid, and so this is what, and this patient has come with CT cysternography, which showed that there is a leak through the right nostril, and the defect was identified at the lateral wall of the sphenoid on the right side. So here I went through the right nostril and opened the sphenoid, and this is the large encephalocele. Remove the turbinate. This patient had features of idiopathic intracranial hypertension. Her opening pressure was also very high. So I did an LP shunt to start with, and then went with endoscopic repair after this. And that's a large herniation, which I tried to shrink. We couldn't shrink it much. So intraoperatively, I just put an onlay graft. So that the mucosa was denuded, created the raw area, put an onlay graft. So just presenting two different kinds of cases where we had multiple defects, and here you have a single defect on both the sides. This is a sphenoid defect, the most common defects that we see mainly in the cribriform plate, and especially in spontaneous and the lateral wall of the sphenoid sinus. So this is the present. Thank you.
Thank you, Dr. Kaushal. Dr. Mohan is not here. So the next speaker is Dr. Krishna Prabhu, and he will speak about complication in skull-base surgeries.
All of you have been hearing about all endoscopic approaches and all the fancy approaches here. But all good things also have another side to it. So the complication endoscopic skull-base surgery is a serious affair, and everybody must be very cautious and be aware of what are the things that can go wrong and how we can avoid it. So if you look at this, this is a huge list of complications that can happen. You see the major complication: vascular injury, stroke, visual loss, diplopia, DVT, meningitis, tumor hematoma, CSF anuria, pneumocephalus, hypopituitarism. And there are some minor complications. So there are a lot of complications that can happen with endoscopic surgery. It's not as rosy as what you think, but there's a lot of complications that can happen, and you need to be aware of it. So if you broadly classify, there are 6 types, as I put here: vascular, neurological, endocrinological, CSF-related complications, infection, and rhinological issues. So I will try to be more constant on the vascular part. So vascular, you can have intraoperative as well as postoperative complications. Intraoperative, commonly that you will encounter in majority of practices, is bleeding from the cavernous sinus, which could look very scary, but actually they don't. If you just be meticulous enough to handle them, they will be settled down. You can also get arterial bleeding from the ECA branches. During exposure, you can get from the ECA branches. You can get bleeding from the carotid artery if there's a carotid injury, if there's an avulsion of vessels. And of course, from the branches of the carotid artery, there's perforators. Post-operatively, you can also have some complications like tumor apoplexy, epistaxis, and ICA pseudoaneurysm. So these things can happen, and you need to be very be aware of it. So as I mentioned, venous bleeding, they're not to worry, they don't panic. Simple packing, warm sun irrigation, hemostatic agents, and you will get away without any problems. It's not a big problem. You can get ECA branches injury while exposure. The 2 things: one is the maxillary artery branch, sphenoparotid artery. You can have it during exposure. The septal branch can happen during the enlargement of sphenodorsal branch. You're also during the tail of the middle turbinate. Whenever you're cutting it, you can also cause injury to these vessels. So you need to be know where these vessels, and if they do happen, you have to identify and cauterize them. You can't pack it. You can't pack an arterial bleeder. You have to identify and occlude it. Carotid injury, yes, it's less than 1%, but it can be devastating, and it can be a fatal outcome if not managed appropriately. Most commonly seen in the region of paraclaval carotid region. So, and most of the time in carotid, the vessel is sacrificed. Almost 60% of the time, the vessel is sacrificed to get out of the situation. And it's generally the people who have done, you see, the most of them on the left side as compared to the right side. Maybe because we're all right-hander surgeons and we're trying to use too much force or doing too much work on the opposite side. You can also have injury to branches of the carotid artery when you are doing expanded approaches, and they are highly vulnerable and fragile because of the size. It can be varying small size to a medium size. And some of these, if injured, cannot be repaired or bypassed. You have to identify and you have to occlude them. And they may not be even seen in angiograph studies. If you don't find them and you pack and come off, you do angiograph and you may not even find where these are leaking from. So that is something you need to be cautious about it. So you need to do it on table, identify it, and cauterize it or clip it. So how do you avoid the carotid artery injury? First is most important is understanding endoscopic IC anatomy. That's the foremost important. You need to be very clear, thorough, entire course, entire branch, where you will get it, and every segment of it you have to be very clear. 2, preoperative evaluation, absolutely important. And use of navigation, it will really help you. Intraoperative Doppler, it's a must for any people who do endoscopic surgery. It's a must, without which I wouldn't recommend even trying doing it. You must have an Doppler. It's not expensive, you can have it. And of course, the drilling of the bone is very important. You have to thin out the bone, eggshell drilling, and then just remove all the eggshells. Do not try to punch the bone without drilling it. It's just dangerous. The other thing you must know is that there are 3 landmarks: that the MOCR and median canal instruction tube. Now, when you identify the MOCR, you're directly over the paraclinoid segment of the carotid artery. When you're over the median canal, is a junction of the horizontal petrous as well as ascending paraclival. So that is, and third registration tube will be the parapharyngeal carotid artery. So these 3 landmarks will tell you where the carotid, which carotid you're dealing with. As I mentioned, preoperative evaluation is absolutely important. If you had a surgery, previous surgery, previously RT done, just go through it and you are going to get in trouble because many a time when you go inside, some of the bones already been drilled, there are scar tissues, and it's not so easy to identify what is the strategy. Two, if the tumor is encasing the vessel, you need to be clear which part and how you're going to deal with it. Make a plan in the beginning. Don't try to make a plan on table. If you decide that you're going to leave behind tumor around the cuff, leave it, no problem. But make a plan, go with it and execute it. Also be aware of variation in the course of carotid artery. Sometimes even up to 15% of the time, the bone may be dehiscent and the carotid that you find the bone is dehiscent and it's a stupid thing to do. Tell the anesthetist, don't keep it high, but just keep it normal hypotensive. Do not do hypotension. To ask him to get blood, transfuse blood. So anesthesia are ready for it. Ask the nurse to get everything ready, all the hemostatic material and all the materials. Also inform your neurovascular team that this patient potentially might come, so they'll be ready, aware, wherever they are aware the suit is ready. As a surgeon, three things you have to do. First, if the assistant is holding the scope, first and foremost, if there is a carotid injury, tell the assistant, do not take the scope out. Even you don't see anything, it's just one blood reddish, you don't see anything, but whatever it is, tell them just stay there. Do not take the endoscope out. Do not take the endoscope out, because once you take it out, it's very difficult to go back to put it through this blood which is coming through and try to place it. And then you take two large sections and try to go through both nostrils and try and clear all the blood which is coming and try to find the region where it is bleeding from. That is the first and more important. So keep the scope inside the nose, do not take it out, two large sections through both nostrils and try and figure out where exactly is the bleeding. If you can get a cottonoid, leave it temporarily, just keep it there, hold it till you sort out the other things. So that's the first and foremost step. So there's some people will say that, you can keep the pressure on the carotid and do it. Well, you can keep it for a very, very short duration, but do not keep it for longer duration, because that will also lead to hypotension and you will have cerebral perfusion is compromised and you may end up having a stroke. So that's also not a good solution. So I will come to. Okay, I will skip this. I'll skip this. Okay. So when you find, okay, you put two suctions, you identify the bleeder, and once you are all happy, the sister is ready, everybody is the thing, you slowly move the plunger to see localize the bleeding. Now, if you hover a suction around the bleeding, it will suck the blood. It will not. So do not keep the suction far away or on the bleeding. Just keep it a few millimeters away so you can know exactly where it is bleeding. First, you need to figure out, is it an extradural bleeding? And so if it's extradural and dura is intact, pack it. You will get away. If it's intradural, packing may not help. You need to identify where it's bleeding from. You need to cauterize it. If the branch can be identified, definitely and cauterize it. If it's an internal carotid artery, if you cannot do anything, you try all these things. You can try claves, packing, everything. Sometimes even muscles too. Because anesthetist, maintain blood pressure, maintain volume, I mentioned. So this is a case which I did in 2016. Now, this is a 42-year-old male, came with bitemporal hemorrhagia. Plus looking, a pituitary adenoma large, look like necrotic in the center. So I thought it should be easy, and we went inside. I mean, you look at it, you probably, decompress the part and the lesion will come off easily. We went inside, we proceeded, and so we opened and we took the tumor out, and then the center part, necrotic part was removed. And so the mistake that I did in this case is that, you see, in my right hand, I am holding the capsule and I'm pulling it. Which is not a good technique to do it. It's not a good technique to do it. You see, I'm literally holding on to it and I'm pulling it. And I did notice that there is some bulge is happening, subarachnoid. You can see something is happening, but I was not. So I thought it's just sometimes, you see arachnoid, it just descends out, it bulges out into, comes out even to it, SL out, even spheres. I thought it's a thing, but you look at the color, it's not looking exactly like a CSF, and boom, it just ruptured. So, okay, as usual thing. So I told my assistant, do not remove the scope. Keep your scope there. We got 2 suction inside. As the initial step, so I thought I'll just put a paddy, and I thought I thought I had an idea where exactly the blood was coming from. Though it was not very clear, but I thought I had some ideas coming from the right side, somewhere on the right side. So I initially kept a plunger to try and find out, and I saw a bleeder. I still do not know exactly where it is coming from. Whenever you have this, as a routine policy that for all my any endoscopic procedures, we keep the thigh draped. We always keep the thigh draped. We don't take it, but we keep it ready in case we need to for any eventualities for muscle flap or facial. So we drape all our patients, keep it ready. So I did repair, but it didn't work. It still continued to bleed. I know it's an arterial bleeder. I know where it's coming from, but I just could not identify where exactly the blood, where the vessel was bleeding. So we tried using cautery, but doing this, not exactly identifying the vessel and trying to cauterize is not a good way because it is not going to work in all your time. So I do not know the thing. Then I tried using a clip. It probably partly reduced, but not completely. Finally, we took a muscle, we crushed it. I packed because I was not proceeding, and I don't think I was thinking. So I packed with the muscle and crushed muscle and packed it and put on a gauze piece and the Foley's catheter, and we came out. So we took the patient straight to the angiogram, and this is what we saw. Maybe see there's a cutoff. There is maybe because of my overpacking. I don't know, but I didn't see any obvious bleeder on the table, in the angiogram table. So as I mentioned, so I did not know the small vessels sometimes may not even know. We did a scan, and this is what the post-op immediate CT scan showed. There's a huge hematoma over there. So we had to go transcranially and evacuate, and we did find a bleeder which was there. We had to coagulated that vessel. That is a learning point. This is another patient, a pituitary male, came with the progressive vision loss with bitemporal hemianopia.
Krishna Prabhu, short of time.
Just 2 minutes. And this patient came with the, so we thought it's a regular cranial pharyngoma. We went ahead. And so we were separating the capsule. See, if you see here, the capsule is little firmly adherent to the chiasm and the optic nerve. And with each pulsation and with each time when I'm dissecting and pulling, the chiasm is getting pulled. And when this happens, a perforator from above or small vessel from above started bleeding from that. But here we knew where it's coming from. I knew where it's coming from. So we went inside, we found the bleeder, we were able to cauterize it. And we had no issues in managing those. So the idea is that you need to look for the bleeder, you need to know where it's coming from, and you need to cauterize it. This is the scan post-op, and the patient doesn't have any much of a problem. One thing that you must do is that whenever you have any venous, any bleeding, always recommend that you do an angiogram post-op. Also, please call for a repeat angiogram after 2 to 3 weeks or 4 weeks, because pseudoaneurysm is quite common in all these patients. So for lack of time, I will skip it. So this I will skip it. So thank you very much. Any questions, I can take it.
Thank you, Dr. Krishnan Prabhu, because we gave a lot of time, because this is very important to know the complications before doing the surgery. The next paper is by Dr. Ayadurai, and he will be speaking on anterior fossa resection in sinonasal malignancies.
Thanks again. I will directly move into the presentations. Thanks, Ramesh, for the opportunity again. Wonderfully organized conference. Sinonasal malignancy as such, like now, it's got a very limited indications endoscopic for endoscopic clearance. 3% of the head and neck cancers are sinonasal malignancy, 1% is malignant neoplasm, and then they always have poor outcome because like you can't have a margin of resection there. Like there's always a limitation for that, even in open surgeries too. They have significant morbidity in relation to the craniofacial resections. The small case example, sinonasal neoplasm, like having the anterior cranial fossa involvement, like the dural enhancement was seen, and there's some changes seen in the brain here. We can make out the involvement here in the axial scans. So this is how we get it from the head and neck surgeons actually. Then we start drilling from lamina to lamella, expose it wide enough to have the anterior cranial fossa dura completely visualized. This is from the frontal exposure anteriorly also. And then like it becomes a classical micro surgery, like always pay more attention to prevent the brain injury or like preserve the underneath brain. So identify the normal dural margins and then start incising it. Go anteriorly, like go circumferentially on either sides, like initially to start with, and then anteriorly. Then when it's difficult to become mobilized, and then like come back and then keep moving around. The Parks cerebri. Then the whole thing comes out, and then the brain is all the time. Like we'll have to pay a lot of attention to keep the brain preserved. ACF resections, all faction has no role. Like so you'll have to be aggressive. Flap down, the pericranial flap down. So that's brought down and then retrieved into the nasal cavity. Kept aside, and then like now one layer of duragen, inlay of the fasciolata, and then on layer of fasciolata, because we need to have a lot of huge big defect. And then the vascularized Pericranium is placed as a last layer, having attachment to all the bone in the surrounding area. Then the standard reconstruction method. So we've done 14 cases. All factory neuroblastomas were 7, and then 4 post-induction SNUCs, and the adenocarcinomas were 3. All were small ones. Like at the onset, they were found. They were not having any too much extensive involvement of the sinonasal area. So we had a CSF rhinorrhea postoperatively managed with Lamborghini. We need not have to be re-explored. We did not have to re-explore any of the cases. There was no flap necrosis. The limitations for the endoscopic ACF resections are maxillary infrastructure and facial structures involvement, orbital floor lateral to the infraorbital, like involvement of orbital floor lateral to the infraorbital nerve, intraconal orbital compartment involvement, and dural involvement lateral to the medial plane of the orbit, extensive brain invasion. So this is my head and neck surgeon, along with whom I went to University of Pittsburgh for the complex endoscopy workshop. We learned it together, and then we formed a team, and then we were able to have good rapport and then bring out a good outcome. The endoscope only approach has a specific indications with the excellent outcome at the onset of the disease progression. If you can find out, and then if you can develop this case example which I had showed you, only similar cases has the indication for the endoscope resections. There's still major role for the craniofacial resection. Again, I thank Dr. Krishna Tej Reddy, who has joined me as an associate consultant in Yashoda Hospital, and Dr. John Jayesh Patel, who is our ENT team. We made a very good team at Amrita. Now I've moved to Yashoda Hospitals. Thank you.
Thank you, Dr. Ayyadurai. I think means we had questions for everybody, but then we'll ask in the tea time because we are short of time.
Thanks, Dr. Manas sir and Dr. Abdesh sir. And we are going, as a short of time, we are going ahead to the next session. We would like to invite Dr. Suchanda madam to chair the session, and also Dr. Artis Naik sir to chair the session.
Good morning, all. We'll move on to the next topic. Endoscopic endonasal step-by-step demonstration of vascular flaps in skull base reconstruction by Dr. Tejasvi. May I invite Dr. Tejasvi? I think she's not there. And we'll move on to the next topic, endoscopic endonasal approach for lesions of cavernous sinus. Dr. Prakash Nair. Is there Dr. Prakash? As we are running short of time, please stick on to the time. All the speakers, I request all the speakers to stick on to the time. Thank you.
So, good morning, and thank you very much for the invitation. Especially congratulate Dr. Ramesh for a very wonderful cadaver session that he had been organizing. So my talk is on the endoscopic endonasal approach for tumors involving the cavernous sinus. And, these are a variety of tumors that you will see in your clinical practice. All of them have some degree of extension, either direct involvement of cavernous sinus or involvement of the tumor that extends into the cavernous sinus, or involvement of the Meckel's cave, which lies adjacent to the cavernous sinus. So a variety of different appearances of tumors of different pathologies. And the first rule would be to understand that each of these are different tumors having different biology. So the approach to them and the surgical strategies to them have to be tailored appropriately. It is not one size that fits all these tumors. There are certain very important landmarks, though, that we need to identify when we want to look for going into the cavernous sinus and dealing with paracellular tumors. And one of them is this concept of the medial opticokerotic recess, which is the keyhole that takes us into the suprasellar cistern, the optic canal, and also onto the sella. So the important part being that when we expose this part, it gives you access to the paraclival segment of the internal carotid artery. This is the siphon of the internal carotid artery that tends to be most commonly injured when we do pituitary surgeries. This is where the injury often happens when we extend our incision laterally, as when we are not aware of its location. So the medial opticokerotic recess or the depression there gives us an anatomical understanding of where we are. And this corresponds to the proximal dural ring that lies on the other side. Now, this has been very extensively discussed, the anatomy of the cavernous sinus and the relationship of the internal carotid artery to the cavernous sinus and how we would go step by step to deal with tumors that involve the cavernous sinus. So if we look at the horizontal segment of the ICA, we can use this horizontal segment to divide the cavernous sinus compartments into the inferior compartment and the superior compartment, and the genu of the ICA to differentiate it further into the lateral compartment. So the important anatomical relationship being that in the posterior compartment that lies behind this vertical segment, you have the sixth nerve that is in relationship with the ICA. In the superior compartment here, in this area, you have the third nerve that crosses into the cavernous sinus and then lies laterally. And in the lateral compartment, you have all the three important nerves that regulate extraocular movements, the third nerve, the fourth nerve, and the sixth nerve. This can also be used as an anatomical indicator for going step by step into the cavernous sinus for resecting tumors that involve the cavernous sinus very extensively. So this is an example of a tumor that has got a large amount of invasion into the sphenoid sinus and to the sinonasal cavity. But for the purpose of our discussion, the important part being its invasion into the posterior compartment here behind the vertical segment of the ICA, into the lateral compartment here, lateral to the ICA, and into the superior compartment here above the horizontal segment of the ICA. So now we know that these are the various compartments that have been involved with a large amount of suprasellar extension. So the initial approach has to be very wide. So I have done a transpterygoid approach. Here you can see V2 and the pterygopalatine ganglion. And this gives me exposure to the entire internal carotid artery on the right side. The initial tumor dissection is started on the left. The tumor is soft and can be, sucked out. We use the Doppler to always give us an idea of where the ICA is. And in cases of venous bleeding, you can always inject a little bit of surgiflow into the cavernous sinus. So the idea being that you get certain amount of surgical control. The second part of this dissection is this bimanual dissection using two suctions to clear out the contents of the sella itself. So you can see the diaphragm that has now descended down. At this point of time, the dissection is taken into the anterior inferior compartment. This lies below the horizontal segment of the ICA. The important factor being that there are no important nerves there. Now, one important thing is that you will often find these small branches that come off the horizontal segment, and these could include branches of the inferior hypophyseal artery. So they need to be taken control of. This is the part where we are going lateral to the horizontal vertical segment. You can see the inferior lateral trunk. So the inferior lateral trunk is a branch that comes out of the lateral part of the ICA and goes onto the lateral wall of the cavernous sinus. And this dissection, so this is the horizontal segment, and the dissection is then taken to the roof of the cavernous sinus. So as we go superiorly towards the roof of the cavernous sinus, you come to the part where the third nerve enters into the cavernous sinus. And you can appreciate this arachnoidal pouch that goes into the suprasellar cistern along the entrance of the third nerve. So you see the caroticoclinoidal ligament, you see the ICA, and you see the diaphragm. So this is one of those techniques where, you use the navigation, you use your clinical and the anatomical pointers to take us systematically from one compartment to another. We are also using neuromonitoring. So this is the neuromonitoring being used to isolate and identify the nerve there. And this is a caveat that I would like to add. I do not explore the lateral compartment of the cavernous sinus routinely for all patients. This is usually done for either very aggressive tumors or for functioning tumors. And whenever we do this, it's also done with a certain amount of caution, because injuries to the cranial nerves can result in irreversible extraocular nerve palsies. These are not desirable when we are actually performing surgery for patients who have visual loss. So this is the end of resection. You have the central part where you have the diaphragm that has descended down. You have parts of the middle part of the cavernous sinus, and you can see the entire compartment of the cavernous sinus of the ICA, which has been dissected. And this is the postoperative image, where you can see a small amount of tumor lying lateral to the posterior part of the, the vertical part of the cavernous sinus. And this is an area that is often difficult to resect when we approach this part cranially, endonasally. And these are certain examples, where even large tumors with bilateral cavernous sinus extension can be resected through the endonasal route. The important thing being that, in some aggressive tumors, you will need certain adjuvant modalities also to control the disease. So this is the example that I had given earlier of the tumor that extends into all these compartments with a small amount of residue postoperatively. So when we looked at our own, experience with large tumors, we saw that whenever we looked at cavernous sinus invasion, when you had higher cavernous sinus invasion, the incidence of gross total resection significantly decreased. Now we come to another concept that Dr. Vamshi had discussed yesterday, and this was about this concept of the resection of the middle cavernous sinus wall. Now, this is an example of a patient who had Cushing's disease, surprisingly with a pituitary macroadenoma, where we suspect some degree of invasion of the cavernous sinus on the left side. Now, one important caveat here is that the endoscope gives you a very good assessment of how the cavernous sinus looks and what the cavernous sinus invasion is like when we look at it directly. So the middle cavernous sinus resection is not a procedure that we would do indiscriminately. It would be tailored patient by patient based upon whether we can identify or maybe, suspect some degree of invasion of the cavernous sinus compartment. Now, here again, I think because the anatomy has already been discussed, I'll be skipping that part, but the exposure has to be very wide. So we go on to expose the entire compartment of the ICA and the vertical segment of the ICA, and then start with the incision that is placed on the normal gland. So it comes, we try to follow the pseudocapsule concept, where the tumor is dissected on the right side. And then we go on to open the anterior compartment of the cavernous sinus. So the initial venous bleeding is controlled using Surgiflow. And we identify these small ligaments. These are the paracellular ligaments. We go on superiorly to identify the keratoclinoidal compartment and then dissect the middle wall away from the ICA. So you can appreciate the genu of the ICA, this keratoclinoidal ligament, which is incised sharply. And one can also see the horizontal segment being dissected. So at no point of time is pressure ever given on the ICA. The ICA is put on one side and the tumor is dissected using sharp dissection to remove this entire middle cavernous sinus wall as one piece. So one can appreciate the genu of the ICA, the horizontal segment and the vertical segment here. And the dissection goes posteriorly till we see the posterior clinoid. So that gives us a complete resection of the middle compartment. Now, why is this important? This patient did achieve remission immediately after surgery and at the end of 3 years, is still in remission. But this is an important finding that we've been seeing in patients where the middle cavernous sinus wall is sampled. We will identify bits of tumor which stain positive for both on IHC for ACTH, which lie inside the folds of dura. This has a great deal of importance when we look at long-term prognosis, long-term recurrence of hormonal activity that happens in many functioning tumors many years after surgery. So the middle cavernous sinus wall resection concept gives us one point of resection, a plane of resection that takes us beyond the normal compartments. However, the caveat being that this is not to be done indiscriminately. It is normally done for functioning tumors and normally done in cases where middle cavernous sinus wall invasion is suspected. So this was the anatomical concept that we were looking at, the keratoclinoidal ligament, the inferior hypophyseal artery, and the attachments of the middle wall of the pituitary to the ICA. Now, we often also see these tumors, where the cavernous sinus has been broken through. So the tumor has involved the cavernous sinus and now has extended into the arachnoidal space, the subarachnoidal space, by invading the roof of the cavernous sinus. And these are tumors that are again more difficult to manage because now you have gone to a compartment which is slightly beyond our axis or beyond the plane that we normally use to reach with our endoscope. So then we have certain anatomical pointers that we can, again identify in this particular patient who had Cushing's disease, had a triad surgery, had then got gamma knife and had CSF leak and repair done. The indication of surgery was persistent and poor metabolic control with a very large tumor that was not at that point of time small enough for adjuvant RT. So here one can identify the tumor that lies beneath the third nerve. You can see the third nerve that extends into the, so there's the third nerve that goes into the cavernous sinus, and the tumor lies just beneath the third nerve. And so the first part of dissection, there's the same one. We go on to dissect the complete ICA, remove the tumor from that particular part, and then open the diaphragm. So once the cavernous sinus has been skeletonized, the diaphragm can be opened to access this component of tumor that lies in the suprasellar cistern. Again, we have some advantages because the tumor is soft, but the incision is then continued posteriorly onto the coryticoclinoidal ligament, which is penetrated by the third nerve. So you can see the third nerve extending from the brainstem onto the cavernous sinus, and this entire dural segment which has been involved and penetrated by the tumor and its extension into the suprasellar cistern can be resected. Now, this patient did have third nerve palsy after surgery, which improved, after 3 months. But the important thing being that, you get significant metabolic control, and this patient now becomes a better candidate for adjuvant treatment. The entire crux of the discussion being that, some of these procedures are not standalone procedures. They are procedures where you might need to combine them with a transcranial procedure, or you might need adjuvant treatment to also manage the disease better. Now, the same concept of dividing the middle cavernous sinus wall and extending into the cavernous sinus can be used for transposing the pituitary gland for accessing tumors that lie behind the chiasm. So this is the example of a large pituitary tumor, a large suprasellar tumor here that lies in the retrochiasmatic space. That I had when I was planning surgery was the fact that, there was a very small corridor between the gland here and the chiasm here. In cases like this, or in cases where the tumor extends below into the prepontine space, removing the posterior clinoid and transposing the pituitary gland, especially in patients who have normal pituitary function, gives us a much wider corridor of access, and at the same time lets us preserve the pituitary stalk and the hypophyseal arteries that feed it. So this is how we would do it. The initial incision is placed on the anterior wall of the cavernous sinus. Once this anterior wall of cavernous sinus is opened at the junction between the inferior intercavernous sinus and the cavernous sinus, this compartment is packed using Surgiflow. We choose this area because here there is a venous compartment that separates the ICA from the medial wall. So this can be accessed. Now we go on to separate these two planes, between the anterior wall and the medial wall, and this can be done very gently using your surgical dissector till we identify the inferior hypophyseal artery. The important caveat here being that the inferior hypophyseal artery can often be very short and stumpy, and it can arise and it's a branch of the ICA, so there can be ferocious bleeding. It is very important that the surgeon identify it and take control over it so that there is no messy bleeding during surgical resection. Once this has been done, the clinoid can then be separated. Again, this is important to note that the clinoid here lies in very close relationship with the genu of the ICA, which goes on posteriorly to be related to the posterior clinoid. So this has to be done in a very meticulous manner. And now the suprasellar dura can be opened, the diaphragm can be cut, and the entire gland can be moved towards one side. This widens the surgical access that is available to the surgeon. Again, because it's a soft tumor, dissection is easier, but the dissection still follows microsurgical principles. And we dissect the tumor away from the undersurface of the chiasm while we are able to preserve these small perforating vessels that go from the ICA onto the chiasm. This is extremely important for preserving the patient's postoperative vision. And following this dissection, the dissection can be continued posteriorly till we get into the ventricle where the tumor extends into. So again, soft tumor which is amenable to suction. And now you can see that the tumor has been cleared from the ventricle also, which at this point of time leaves us with the surgical relationship where you can see the pituitary stalk, the left-sided superior hypophyseal artery, and the ICA. So these are large tumors that can be accessed and resected very comfortably using this wider corridor that we get after chiasmal transposition. And for the want of time, I'll skip the video, but we can also do large petroclival chondrosarcomas that involve the retrocellular space and the upper part of the clivus using this technique. So to conclude, why this medial transcavernous approach? So for tumors that lie in the midline, like pituitary adenomas, the corridor created by the tumor gives us a natural avenue to go into the cavernous sinus. And the trajectory of the approach lies medial to the cranial nerves. So the cranial nerves 3, 4, and 6 lie in the lateral compartment. And this gives us a natural trajectory that keeps us medial to the cavernous sinus, medial to those cranial nerves. For chordomas and chondrosarcomas, where the tumor itself arises from the bone and soft tissue, it allows us to resect the soft tissue and bone, which gives us a wider margin of clearance. And when we use this transposition to access the interpeduncular space, it minimizes the amount of chiasmal retraction and also allows us to preserve the stalk. So there are certain applications like middle cavernous sinus wall resection, cavernous sinus invasion by pituitary tumors or chordomas, transoculomotor triangle approach for tumors going through the roof of the cavernous sinus, or for tumors that involve the Meckel's cave. So in conclusion, the surgical approach is determined by identifying the relationship between the dural layers and the type of the tumor. And the endonasal cavernous sinus transcavernous approach gives us the middle aspect or middle approach to the cavernous sinus. It minimizes the manipulation of the third nerve, the fourth nerve, and the sixth nerve. And very important to evaluate the anatomy of the ICA and also the relationship of the tumor with the segments of the ICA. And at the end of the day, it's meticulous skull-base reconstruction is essential to prevent CSF rhinorrhea and all the other complications. So thank you, and thanks to the team at Chitra, for helping all consultants do all this work.
Thank you, Dr. Prakash. Do you have another talk as well, right?
Talk is yours. Sir?
This is the next talk you're
Yeah,
doing right now, no?
I think without pause, I'll go on to the next part of my talk, which also covers our approach, which takes us lateral to the ICA in the coronal plane. So we have just spoken about our approach, which lies just lateral to the sella, with tumors that extend into the cavernous sinus. So what if we need to go even further laterally? What happens when you have tumors that go down inferiorly involving the petroclival synchondrosis and the retrocarotid space here? Or for tumors that are primarily midline but also come into the petroclival synchondrosis here? Or large tumors like this that involve the clivus and involve the prepontine space. So what is common to these tumors, and why do we need an axis that takes us lateral to the midline and brings us to this area which you call the petroclival synchondrosis or to the petroclival space? Now, the petrous apex, which lies at the center of this approach, can be approached by a variety of approaches. We have the anterior petrosectomy, you have the translabyrinthine approach, or we even have the combined approach, where you can do a retrosigmoid and then combine that with a posterior petrosectomy to come into this space. But the anterior transsphenoidal space, which uses the transpterygoid corridor, gives us certain advantages. So the anterior transpetrosal approach has certain limitations. One of it is the limited ability of this approach to access the clivus. And there is a certain amount of drilling of the ICA, drilling close to the ICA, and a certain amount of retraction of the temporal lobe. On the other hand, when you have these posterior petrosal approaches, they do not give us access to the clivus. And you also are forced to sometimes, retract the temporal lobe, which might cause injury to the vein of Labbé. And even in the best of hands, in contemporary series, the extent of resection for tumors like chordomas remains still very low. On the other hand, when we think of planning the transpterygoid approach, we need to know certain important anatomical pointers here. So one of them is the relationship of the pterygoid process, which is the lateral part of the sphenoid, which gives attachment to the medial and the lateral plates of the pterygoid. This contains two important foramina. One is the foramen rotundum and the other is the Vidian foramen. Now, based upon this relationship of the foramen rotundum and the Vidal canal, you can divide our approach into areas that access the sinonasal tract in the midline, or the pterygopalatine fossa just lateral to the sinonasal cavity, or even further into the infratemporal fossa. When we look at this relationship superior to the Vidian nerve, you have this compartment, which is the lateral recess, where we had seen a presentation about CSF rhinorrhea. And this is where you have leaks or encephalocele that protrude from the temporal lobe. And you can also have an approach to the middle cranial fossa, which is beyond the purview of my talk right now. But this allows the surgeon to take his resection into the petrous apex, to the jugular foramen, to the pterygopalatine fossa, or into the infratemporal fossa, depending upon the extent of the tumor. Now, there are certain, older classifications where you call this approach with its variations as a medial, a suprapetrosal, or an infrapetrosal approach. But for the purpose of my talk, I feel that sometimes this classification is quite artificial. However, the transpterygoid approach helps us in certain ways. The first is that it gives us a very direct access of approach. So it makes the approach very linear. It also allows us to move our instruments in this limited space in a more efficient manner. And it allows us to isolate the genu of the ICA, which lies at the center of our approach, by allowing us to identify the median nerve. Now, the median nerve always is placed in the inferior and the medial aspect of the genu of the ICA. So this allows us, or gives us a roadmap to access the genu of the ICA very directly. And in cases where it is required, you can also mobilize the eustachian tube. So this is the concept of the pterygoid wedge. So you have the sphenoid sinus that has been opened as a routine that you see in pituitary cases. You have the medial aspect here where you see the rostrum or the keel of the sphenoid sinus. And then you have this bony projection laterally, which is the pterygoid wedge, which needs to be drilled for, the initial access into this particular space. And this is the relationship that you see between the median nerve and the internal carotid artery. So the carotid artery transitions from the laceral segment into the cavernous segment at this point where you call it the genu. And one of the anatomical pointers that we can use to identify the genu of the IC is the median nerve. The other is the pterygosphenoidal fissure. So this video is to basically show you how we can, use all these anatomical pointers to come to mobilization of the ICA. So here we have a patient who has a tumor involving the posterior part of the clinoid, and the tumor extends along the petroclival synchondrosis all the way down to the petroclival fissure. Now, this is a common presentation in a patient who may have a petroclival chondrosarcoma, where the presentation might be with third nerve palsy. So the initial steps of the approach involved a maxillary antrostomy, ligation of the sphenopalatine artery, identification of the pterygopalatine ganglion, skeletonization of the median nerve, and then lateralization of the pterygopalatine ganglion with drilling of the pterygopalatine with the pterygoid wedge to give us access to the genu of the ICA. So this is a view into the right nasal cavity. In this particular patient, because the tumor is on the left side, the antrostomy and the pterygoid mobilization will be done on the left side. So because the sphenopalatine artery is going to be ligated on the left side, any flap for reconstruction has to be done on the right side. So once we get a view of the nasal cavity and lateralize all the turbinates, we come to the left nasal cavity where we do a turbinectomy for further space. This is then followed up by an uncinectomy. So when we do the uncinectomy, you now start to see the maxillary sinus, and we open the ethmoidal bulla till we see the middle wall of the orbit. So once we've done the antrostomy, we start to visualize the posterior wall of the maxillary sinus. So you can see the open antrostomy and the relationship of the posterior wall of the maxillary sinus. And ethmoidectomy is also done to increase the surgical corridor of access that is available for us. So at this point, you see the posterior ethmoidectomy, you see the medial antrostomy, and then we start to isolate the sphenopalatine artery. So when we lift this mucosal fold, we come to a small elevation of bone that is called the crista ethmoidalis. And once we start removing this, we can start to appreciate the lower part of the pterygoid, and you can start to appreciate the sphenopalatine artery. So we coagulate the sphenopalatine artery, we cut it, and then remove the bone further. So in the pterygopalatine fossa, we know that the vessels are situated anteriorly and the nerves are situated posteriorly. So once this is done, we take a small rescue flap. Now, depending upon your requirement, the anxiety for managing CSF leaks and the size of defect that you anticipate, you can harvest a nasoseptal flap prior to surgery, or you can just do a rescue flap and then plan a nasoseptal flap later. Then we do a posterior septectomy to make this a unicompartmental cavity, where you have a wide posterior ethmoid, sphenoid opening, which you call your 1.5 cavity or a 2 cavity concept. Now we lateralize the pterygopalatine ganglion. So the pterygopalatine ganglion is identified, and we go on to isolate the foramen rotundum. So V2 coming out of the foramen rotundum. We now skeletonize the median nerve. So this is the median nerve being skeletonized. This is the median canal. And once this is done, you can cut the median nerve. So once the median nerve has been cut, the pterygopalatine ganglion can be mobilized laterally, and you get a much better view of the pterygoid wedge. Now this can be drilled, and now we take this drilling to further isolate the entire internal carotid artery. The clivus also has to be drilled so that the medial aspect. So this is the median nerve. You can appreciate the stump of the median nerve, and the drilling is always done in the inferior aspect of the median nerve to make sure that the ICA that lies above it is not harmed. Again, drilling is never, or very rarely done on the ICA directly. We drill on either sides of the ICA, make the bone very thin, and then chip the bone off so that the amount of drilling that you do on the ICA is minimized. And at this point of time, this is a lingual process, and you can slowly chip the bone off till the entire segment of the internal carotid artery up to the foramen lacerum has been freed. So now the ICA has been freed, the ICA can be mobilized. So this now is then corroborated using a Doppler. So the Doppler is used to make sure that the entire course of the ICA is identified. We then again open the anterior wall of the cavernous sinus and take a dissection superiorly. Here you can appreciate this ligament. This is the caroticoclinoidal ligament that is attached to the genu of the ICA. So the caroticoclinoid ligament continues laterally as the distal carotid ring. And now we come to the space where you have the tumor. The tumor is inside the bone. The entire tumor can be removed piecemeal. That's the posterior clinoid being detached completely. And then you can see that, this is one compartment. You have tumor in the posterior clinoid, and this is the petroclival skin chondrosis inferiorly. And these are areas from where your chondrosarcomas normally arise. So this is using a nerve stimulator. We go on to try and see where the sixth nerve is. The sixth nerve normally comes from the posterior fossa into the cavernous sinus by this route. So now you have the entire compartment of the ICA, and this is the reconstruction. So this is the exam. This is the resection that you get. You have resection that takes us posteriorly, but also a complete resection of the tumor in this particular space. So this patient had a petroclival chondrosarcoma, and she had normal extraocular movements after surgery. Now, this is another example of the same concept where you have tumor.
I think you are over time.
Okay. So I'll just present my concluding points. So to conclude, the endoscopic endonasal transpterygoid approach can give us extension for approach for tumors that extend lateral to the ICA into the petroclival synchondrosis. The Vidian nerve is an important landmark to identify the genu of the ICA. And this extended endonasal approach can give us access to the petrous apex, to the jugular foramen, to the infratemporal fossa or the petroclival synchondrosis. And more importantly, it extends the corridor of resection available. And it improves the extent of resection that you can get for tumors. Naturally, like I showed, most of these tumors that require this approach are tumors like chordomas or chondrosarcomas, where the tumor itself is inherently resistant to radiation. And a wider or a better resection always gives the patient a much better quality of life. Thank you.
Thank you for the brilliant lectures. Unfortunately, we did not have enough time to see all your slides. But next, we would like to hear from Dr. S. Dandapani, and he will speak about endoscopic endonasal step-by-step strategies for complex giant skull-base tumor.
Good morning, everyone. I would like to thank Dr. Ramesh for organizing this excellent workshop. So I think all of us are learning from each other. It is really wonderful. These kind of workshops actually make us better. So I would encourage everyone to attend more of these workshops, and residents and younger faculty, younger neurosurgeons learn more so much, and we learn from young neurosurgeons, and so it is mutual. So I would like to focus on endonasal strategies for giant intracranial tumors. So basically, I think there is no debate why endonasal endoscopy is superior to microscopic surgery for most of the tumors which are larger than a simple microadenoma. So there is so much evidence, and we need to learn to use navigation and angled endoscopes to utilize the full advantage. Only 0-degree endoscope alone is not sufficient because we are wasting the potential of angled optics. And whenever I want to highlight the superiority of endonasal endoscopy for craniopharyngiomas, how much ever great neurosurgeon you might be, if we do a transcranial approach, there is no way you can look visually, you can look at the hypothalamus, like mammillary bodies, which are having great evidence to show that in children, if you preserve the hypothalamic structures adjacent to mammillary body, the outcome improves tremendously in the long run. So in transcranial approach, there is no way you can visualize this kind of center. This is the mammillary body. This is where if you damage, patients will develop metabolic syndrome in the long run. In endonasal endoscopy, you can see and then you observe them. So that is the superiority. In most of the cases, sometimes it is not preserved in a retro kind of clival craniopharyngioma, but we always have to identify the mammillary body and preserve any invasion. And other thing is that under surface of the optic chiasm. See, there is so much debate on residual tumor complications. Yes, I totally agree. Transcranial surgery has a definite role for any complex tumor which can have vascular complications and in which, but whenever you think you can do a gross total resection, the visual outcome is tremendously superior because you preserve and the vascularization of the undersurface of the optic chiasm. So that is having a great evidence to show that visual outcome is superior. There is no debate about it, even in cases of meningiomas. And because you achieve early optic decompression, and most of the time when you get into the tumor, you have already devascularized the tumor. We hardly face kind of severe bleeding when we are doing endonasal endoscopic surgery, if we are remaining in the right plane. And of course, we don't retract the brain. So these are the advantages, and you see the whole circle of Willis. And if any kind of encasement is not there, you have ruled out. And if you can remain within the plane of the tumor, the complications, vascular complications are minimal. So selection of cases is very important. CT angiography we do in all cases. Other thing is that undersurface, if a tumor is stuck to the undersurface of the optic chiasm, there is no way with transcranial surgery to look at it unless you use an angled endoscope through transcranial approach. This kind of dissection and then separating from the vessels which are like arising, like this is the posterior circulation, PCA, PCOM. So you identify them early and you dissect. But in transcranial surgery, you don't visualize them very, very early. So if a tumor is there. So these are the advantages. And even without a transpterygoid approach, with using angled endoscope, you can look at all the 4 compartments of cavernous sinus, which has been beautifully described before. So you have this 6th nerve in the lateral compartment and superior, posterior, inferior. This is purely by using a conventional approach using angled optics. So there is 2 ways you can kind of remove the tumor by visualizing. Either you do a good exposure. We often recommend it in tumors like this kind of meningiomas, or you use angled optics and angled instruments with minimal exposure to get the tumor out. So in meningiomas, you have to have a very good exposure because the base of the tumor is broad and you have a kind of dural tail. So in these kind of tumors, we have a kind of, means we have made it simple by giving this kind of 10D steps. First, we take the flap, we do extensive drilling, durotomy, and by the time you enter the tumor, it is already devascularized. Then we try to do maximum internal decompression, and then we detach the tumor all around, and then we dissect. See, dissection is the most important step. Sometimes when we are showing videos, we don't highlight that, but dissection, if we do properly, gradually, and then the delivery looks very pleasing. But the key is in dissecting the tumor all around. And always the proximal vessels have to be exposed first, like how we do it in aneurysms. Then even if something happens, you can always have a control. So we always identify the vessels A1, ICA on either side. And then gradually we start rolling the tumor, we start exposing the ACOM. So in that way, you'll always have a control. So that is very key. and then gradually we can roll the tumor with angle. See here, the endoscope is in the floor. The instruments are on the top. So in that way, without having, just you need to have an exposure beyond the dural tail. So that much is sufficient to have a very good excision, and bilateral optic canal can be deroofed and tumor can be excised from them. So these are the advantages. And another advantage for small tumors, yesterday there was a question, small tumors, why you have to do an aggressive surgery? But actually endonasal surgery can be a pure extra-arachnoidal surgery for meningiomas. This is a very small tumor. There is a good sphenoid sinus. If sphenoid sinus would not have a good kind of nematization, I would agree. But in this case, it comes like a pituitary tumor, actually. This tumor had been devascularized. You can see the arachnoid. You don't see optic chiasm. You don't see any subarachnoid. You don't get CSF leak. It is actually a pure extra-arachnoidal meningioma. Most of the small tuberculum cellae meningiomas are extra-arachnoidal and they can be removed even without a single drop of CSF coming out. So this is definitely superior to any transcranial surgery in which you violate the arachnoid and then you go into the tumor. So here, this kind of surgery is definitely superior. So even for small tumors, this one is far better. And in pure third ventricular craniopharyngiomas, in this case, it's a papillary craniopharyngioma. The other approach is you come from the basal interhemispheric approach, but lots of perforators are there in this corridor. So we chose to do this. But again, the disadvantage is here because you see the stalk is attached to the tumor. Chiasm is inferior. This is the chiasm. And the tumor is superior in the third ventricle, the stalk. So here we had to explain the patient that if you want to do gross total resection, we'll have to sacrifice the stalk. And then we cut the stalk, we entered the third ventricle, and then the whole tumor. See, third ventricle is very good because attachment is only onto the base. Once you have detached the tumor, you don't have to bother. The whole tumor comes out because there is no attachment superiorly, no attachment laterally, only inferior. Only the stalk had to be sacrificed, and then we can achieve a gross total resection in this case. So another case, this was a child with a pure third ventricular craniopharyngioma. As you see, craniopharyngiomas arise from the floor. So the tumor itself gives you a doorway to enter the third ventricle. So we do a kind of customized exposure based on the chiasm. And then you see the tumor is kind of opening up the corridor here. And then once we dissect the tumor here, you don't have to do dissection superiorly. Only the lower part you need to dissect. Then the whole tumor can be delivered. And then we can see here the lilicus membrane is intact. Even the stalk is intact because we went anterior to this is the stalk. So you can preserve the stalk kind of by choice. And this is another case of a very young child with craniopharyngioma. Here the tumor is extra-arachnoidal. So here we can do that internal. We don't do the trans-tubercular approach in such small tumors. We enter the cavity, and from within the cavity, we remove the capsule using angled optics. So these are the various ways we can customize our strategy depending upon. But whenever there is a large cavernous sinus invasion, I think Dr. Prakash has already covered, transpterygoid is very good. But sometimes even without transpterygoid, you can do it if there is a large opening in the medial wall of the cavernous sinus. But in this case, because it is going lateral, we did transpterygoid also, and growth hormone decreased from 50 to 1.4. So, and in giant tumors, first we remove the central portion, then cavernous sinus portion, then we remove the suprasellar portion, so that the tumor descent, the diaphragma descent will not impede the entry into the cavernous sinus here, because if you want to enter the cavernous sinus from the medial wall, it is better to do in this way. And sometimes the tumors, there are some tumors which still have a role in the transcranial approach. I'll just show, when you are coming from right side, as you start removing the tumor, you visualize the contralateral undersurface of optic nerve and carotid artery better directly, because we are looking at the contralateral side. And then gradually, as you start decompressing the tumor, we see the pituitary stalk. And then when you use angled optics, then you can see the ipsilateral undersurface of the optic nerve and the kind of the ophthalmic artery. So this is like some tumors, transcranial approach is better. but still when we use angled endoscope, it becomes better to visualize the ipsilateral undersurface, which is not possible with a conventional transcranial approach because it is in the kind of blind spot. So when we use, this is with zero optics, 0 degree, and this is with angled optics. See how you see the ophthalmic artery, which is not possible with 0 degree visualization. And then you can visualize the optic canal also on the ipsilateral aspect better with angled optics. So the main advantage of endonasal approach is that you can tackle bilateral medial optic canal and do early non-traumatic symmetrical optic decompression, which is kind of proven to have a better visual outcome. So, but whenever there is a dural tail laterally, we prefer transcranial approach, and whenever there is a vascular encasement. So we always look at the coronal views and see the dome of the tumor, which is going lateral, can be rolled, but the base of the tumor, this part of the tumor cannot be rolled because it is beyond your approach. Here, no, you cannot do lateral beyond the kind of optic canal area. So here you have to go for transcranial approach. Sometimes you can do a combined approach utilizing both endonasal as well as transcranial keyhole approaches. This was a case of a chondrosarcoma. And in this case, this was a totally kind of, this was a case of McCune-Albright syndrome with a giant GH secreting tumor. So here even transcranial would have been difficult. So we preferred to do an endonasal endoscopic. We made a kind of tunnel, and using angled optics, we removed the tumor. So when we talk about how to strategize, see, for a giant pituitary tumor, you need to have a broad exposure. You have to include the tuberculum, which Dr. Rao had beautifully highlighted. But in these tumors, rather than going so much exposure, you can use angled optics to utilize the advantage of this this must be a supradiaphragmatic extension, which is likely to be extra-arachnoidal. So you can use angled optics rather than extending the bony exposure. And in craniopharyngiomas, some tumors you need a broad exposure. Some tumors, which I have already shown, you need because you go through a narrow window between chiasm and pituitary. So with angled optics, you can do with a minimal exposure. So no need to have a generalized broad exposure for all cases. In these tumors, it is a subarachnoid lateral extension. Here again, transpterygoid approach will not give you a greater advantage, but angled optics and angled instruments will give you better visualization. For meningiomas, we have to have a broadest exposure. And these are some of the cavernous sinus, the kind of subarachnoid tumor invasions when we used angled optics, and how the vascular even when there is an encasement of ICA bifurcation, we could take out the tumors. And in cavernous sinus, we do transpterygoid for select cases for getting good control, especially for functioning tumors. Non-functioning tumors, depending upon the feasibility, we try to do. For meningiomas, I have already highlighted the extent of exposure needed. And again, it is customized even for craniopharyngiomas also, depending if the base is broad, you do a broad exposure. If the base is narrow, we do with a minimal exposure and angled optics. So depending upon the base of the tumor, we decide whether we want to do an aggressive exposure or whether we want to do a minimally invasive approaches. So that, and again, transcranial approach has still a role, especially in tumors which go lateral to the optic nerve and and lateral to the carotid artery. So large and giant tumors need to be approached with planning and caution, and each tumor need unique strategy. Thank you.
Thank you, sir. Thank you. Then we'll move on to the next paper. Endoscopic endonasal step-by-step approach to orbital tumors by Dr. Avdesh Jaiswal.
At the outset, I am thankful to the organizing team and Dr. Ramesh for giving this invitation. I will be presenting a video showing the various steps involved in the endoscopic endonasal excision of a orbital tumor. Basically, this approach is restricted to tumor which are located predominantly in the medial part of the orbit, as you can see here. भाई हेलो काम नहीं कर रहे हैं you need to know, do only ethmoidectomy here, which is very easy procedure, requires only 10 minutes under endoscopic guidance through the nose, and the entire middle wall of the orbit will be in front of you. How you do it? There are 4 gates from anterior to posterior, which have to be opened one by one, like uncinate process, bulla ethmoidal, ground lamella, and anterior sphenoidal wall. As you can see here in this schematic diagram, first you have to medialize the middle turbinate, and the entire work is done in the middle meatus. Then you remove the uncinate process, then bulla ethmoidal, then ground lamella, which is nothing but the part of the middle turbinate which attaches with the lamina papyracea. And then you open the anterior sphenoid wall, and the whole of the middle wall of the orbit will be in front of you. And you can approach the tumor. So this is illustrative case, patient presented with left side proptosis. You can see here the radiology. The tumor is predominantly located in the medial of the orbit. The optic nerve shifted superiorly and midly, you can see here. And the tumor can be approached very well with this endonasal endoscopic route. This is the video. You can see here, this is the middle turbinate. This is the uncinate process, which is the only mobile structure present in the lateral wall of the nose. And this is the bulla ethmoidal. So the middle turbinate is medialized. The work is being done in middle meatus. Now this is the uncinate process. Using backbiter, we are doing an uncinectomy. You can do, this is retrograde uncinectomy. You can do anterograde also. And after doing the uncinectomy, you expose this to bulla ethmoidal. This is the largest anterior ethmoidal hair cell. You open the bulla. And once you remove the bulla, you can see this is ground lamella. This is the middle turbinate. This is the ground lamella attached with the lamina papyracea here. You open the ground lamella, which forms the partition between the anterior ethmoid hair cell and the posterior ethmoid hair cell. Now you enter in the posterior ethmoid hair cell. Just break the various partitions. And then now, then what I'm doing is opening the maxillary sinus, widening it. This is required because this prevents postoperative maxillary sinusitis in this which often occurs in this approach. This is the maxillary sinus wide opening of the maxillary ostia. This is the posterior ethmoid hair cell. And then you identify a very important landmark, that is superior turbinate. This is superior turbinate. And everything lateral to superior turbinate is the posterior ethmoid hair cells. You need not worry about it. Just identify the superior turbinate. This is superior turbinate. And this is the anterior sphenoidal wall. Okay. So this is the posterior spider cell, posterior wall of the anterior spider. This is the superior turbinate, and this is the anterior sphenoid wall, which is present lateral to the superior turbinate. You open it, then you enter in the sphenoid sinus. So this has been opened. This is sphenoid sinus mucosa. You take it out. And this procedure doesn't require more than 10-15 minutes, not very easy. This is the protuberance of the optic nerve. This whole structure is the lamina papyracea. Now removing the lamina papyracea, and underlying you can see the periorbita. This is periorbita seen. Very thin bone. Required only a dissector to take it out. And depending on where the tumor is, you can remove the lamina papyracea. You can see this is the periorbita seen beautifully. So till now, the procedure is done with one nose. After this, we make a small window and make it binostril to better manipulation of the instrument. Now making incision over the periorbita. You can make a horizontal incision. I usually make a vertical incision, then a horizontal incision, vertical in the interior part, because the tumor is present in the interior part of this orbit. And once you open it, then the fat protrudes out. This is very problematical because you have to dissect between the fat. Sometimes it's very troublesome. You may remove excise amount of fat. So now dissecting the fat and identify the medial rectus muscle, which underneath. This is the medial rectus muscle. And now this is projection binostril. And once you identify the medial rectus muscle, just hook it up and make a corridor between the medial rectus and the inferior rectus muscle. So the medial rectus muscle is being now hooked up. And you visualize the tumor here. So the medial rectus muscle now detected with the suction, and this is nerve to inferior rectus muscle. The tumor is being dissected from all around. The assistant holds the scope here. We don't use any endoscope holder. And once you see the dissect the tumor from all around, just take a biopsy forceps, grasp it. At this time, the assistant pushes the globe, put a digital pressure over the globe to facilitate the entry of the tumor in the nasal cavity and better dissection using traction and counter traction. At the same time, assistant is pushing the globe inside. Tumor is being dissected from all around. And you see, first dissection is done inferiorly because the optic nerve was situated superiorly. So taking out tumor from inferiorly first, and the superior part comes through the inferior part. So rolling the tumor from all around, separating it, putting digital pressure. Gradually, the tumor comes out in the nasal cavity. Some small attachment, you may coagulate it and then cut it. And the tumor comes in toto. The biopsy was this tumor was hemangioma. If it's schwannoma, sometimes you need to add Dr. Nishikant sort. You may require to remove in piecemeal. And once the entire tumor comes in the nasal cavity, you can take it out through nose. The hemostasis with some amount of Surgicel. You need not require any reconstruction. But nowadays, we are putting the septal cartilage over the defect area. This is a post-op imaging. Complete tumor had been excised. This is a specimen by cavernoma. The patient proptosis resolved immediately after surgery. Thank you very much.
Thank you, Dr. Avdesh, for keeping the time. In fact, you are ahead of time. And next we have Dr. Ramesh Tigala, and he will be speaking on endoscopic endonasal step-by-step demonstration of CSF rhinorrhea repair.
Good morning. At this outset, I would like to thank Dr. Ramesh for organizing this wonderful conference. This is almost like repetition of a morning talk by Dr. Kaushal, and I'll share my views. Any abnormal communication between the cranial subarachnoid space to the nasal cavity through a osteodural defect is called the CSF rhinorrhea. We'll be focusing mainly on the spontaneous CSF rhinorrhea because traumatic and iatrogenic are totally different entities, so I don't want to mix them too.
So this purely on a spontaneous CSF leaks. Causes could be like focal atrophy of the olfactory bulb due to raised intracranial pressure or the benign intracranial hypertension. This is the commonest cause which we see in our practice. Defective development of the cribriform or some congenital defects leading to the encephaloceles in meningoencephaloceles. These are the armamentarium of the cases which we commonly encounter. And most of them, they present with the intermittent CSF leaks with intermittent meningitis features. So untreated cases, there is an incidence of 10% meningitis annually. So there is a reason why they need to be properly evaluated and managed accordingly. The clinical spectrum will be like active leak in anosmia, recurrent meningitis, headache, and BAH. So many times we think that just plugging the defect is the ultimate goal of the treatment, but it's not true because it is a close network between the neurosurgeon, ophthalmologist, neurologist, and an ENT colleague. Predominantly as neurosurgeons, we routinely don't treat these cases. Mostly they go to the ENT colleagues. But in recurrent cases, because spontaneous CSF granulosis is not only a matter of repair, but you need to check the CSF pressure dynamics is very, very important because that is one which is been neglected by the other departments where we have a direct access to manage the CSF pressure dynamics is important in this case. So this is the practical algorithm what I use. Like any clinical suspected case, we get the imaging to check the defect and also ophthalmology or neurology evaluation to see any pressure evidence if it is there on the optic nerve. So if you have a signs of benign intracranial hypertension in this case with associated active leak, we go for the repair. And if there is no leak, but features of BIH are there, then we try to measure the CSF pressure. And if the pressure is more than 20 centimeter of water, we go for a CSF diversion without any defect close at that time. And if the pressure is low, we follow them with the conservative management on a regular basis. If there are no signs of BAH and still there is an active leak, because most of the time when there is an active leak, the pressure will be obviously less. So even if you monitor the pressure at the time, we don't get the actual targeted pressure values to repair. So if there is any active leak, even without the features of BHS, we go for a repair. If there is no active leak, and then even after the repair, because once we close the defect, then we start seeing the mounting of the pressure. That's the reason why post-operatively also we follow them closely with the ophthalmologist. And within a month's time, we are able to check the pressure. If the pressure is more, then we follow the same algorithm. So that's how we manage these cases. The CT MRI is important because mainly these are the findings which we get on the MRI. Highly titulated images with the fast spin echo are the one which will show the defect without any invasive procedures, and better will be done in the prone position if the flare sequence will differentiate between the nasal secretions because the CSF or the nasal congestion. These are the one thing. And other features which are associated with the empty sella syndrome, Meckel's cave diverticular, these are the features we commonly see if there is a patient having features of the BAH. CT predominantly will be done to check the bony defect mainly and any other prolapsing soft tissue through the defect. And the fluid accumulation sometimes in the sinuses also can be appreciated with the help of the CT. So once you have done these things, then it will be easy for us to go for the these things. The technology is evolved over a period of 100 years, but the gold standard is practicing for the last 4 decades. That's mainly which was described by the Wiegand. It is less morbid and excellent visualization with the help of endoscope so that we can precisely pinpoint the defect where it is in the skull base. And the success rates are to the tune of nearly 90%. So the surgical principles again, like preoperative lumbar drain on cases where the large defect is there, using the navigation guidance. I routinely use the navigation guidance. We use the Strauss endoscope. Periumbilical fat or the facial latter will be the one which will be prepared for the defect closure. It will be done in 2 or 3 layers using the fat, fascia, cartilage, and mucosal, local mucosal grafts. Nasal packs, meroseal or uninostril approach is the commonly which we practice. And drain removal wherever we put the drain after 48 to 72 hours. After blocking it for a small period, see if there is no active leak, we remove the drain. So depending upon the leak, it can be direct paraseptal approach. If it is a cribriform plate leak, if it is a fovea centralis, you can go through the transethmoidal approach. And in cases of lateral sphenoid wall defects, because it is mainly the pneumatization, hyperpneumatization of the sphenoid sinus, greater wing of the sphenoid sinus, if it is pneumatized because of some congenital conditions or the raised features, these can be approached through the transtergate approach if it is too lateral. And sometimes medial also you can go using the angled approach. So small defects with a very less than sub-centimetric defect, we can use the bath plug technique, which is plugging the fat into that. And we'll try to snugly fit the fat into the defect, which will show the case. So this is called the bath plug technique. Other variations is like you can use the multiple grafts onlay or inlay depending upon the defect and your comfort. I will take you through few cases. Like this is the young lady presented with a small fovea centralis defect here. Defect, and approach is like the moment you enter into that, you can see the small encephalocele prolapsing into the nasal cavity. You shrink the defect because as the time, depending upon the time delay, the encephalocele can grow in size. But when you shrink and follow the defect will be small. Like usually, most of the defects are sub-centimeter. This is a scarred gliotic tissue. So we excised it completely. You can see the dural defect there. That is less than a centimeter size. So once you identify the defect, it is easy to close. You cauterize the margins, and the raw area of the brain was covered with the piece of Sagicel. And later we used a small piece of facial after graft, and the fat was plugged into that one. And many times, because free fat graft can dislodge, so to cover that one, we use the local terminate covers or the maybe mucosal cover over that to give a support actually. Here, after placing a fat cartilage, we turn the partly sectioned the middle terminate to switch over onto the graft as a onlay graft over the defect. This is another case with the midline defect, cranial plate defect. So actually, this lady was a practicing doctor. She was operated for a convexity meningioma almost 6 years back. After the surgery, for 2 to 3 years later, she started having a leak. She was thinking that it is because of the operative defect. She never gone for any further evaluation. She was continued to have repeated leaks every 6 months or 1 year. Then I persuaded her to go for the further investigation. When we investigated, we actually saw that it is not the same defect. It is a different defect which in the anterior skull base. So we have to operate this case without having any further delay. So this is a defect where a part of the brain encephalocele was going into the nasal cavity. We measured the pressure because she was insistent. So that time the pressure was around 20 on table because we put a lumbar drain, and that time only we pressured the monitor intracranial pressure was 20. So sorry, this video was not playing. Anyway, I'll switch that one. So post-surgery, after 3 weeks' time, we measured the pressure is around monitoring this case without any further leak. There's another case with, sorry, not videos are not playing. No problem. No, it is here. Yes. This was a case where we managed this with a small bath plug technique. So we tie a small suture into that and we plug the fat to snugly fit into the defect. So that's what the bath plug technique. So this was the case which I told, like previously operated case. So large encephalocele was collapsing into the nasal cavity there. So we used the middle terminate to as a graft. We raised it as a flare after the defect was identified. The margins were totally separated from the dural defect. And the prolapsing arachnoid along with the defect was snugly coagulated to get the fresh defect margins all around. Once that is identified, we use a The raw area of the brain was covered with the gel Surgicel, as I told in the previous case. And a small piece of facial after graft was harvested to cover this defect. So nicely packing this one, and after that one, we use the middle turbinate. Fat was kept over the facial latter, and the middle turbinate was sliced to get the larger area of coverage, and it was used as a local harvesting flap onto the defect. So it was sliced and placed onto the defect to give the sandwich effect. So this was another case. And one last case was a lateral sphenoid sinus defect. I'll show the images later. So we operated this through the transmaxillary transpterygoid approach. The posterior wall of the maxillary antrum was drilled to enter into the lateral wall of the sphenoid sinus directly. This is when we entered into the pterygoid fossa and opened that one. So the encephalocele was almost completely plugging into the. So this was when we entered into the sphenoid sinus, the encephalocele was plugging into the lateral sphenoid sinus completely. It was shrinked and denuded tissue was cut to expose the defect here. Just a minute. So we removed that one, and then the repair was done with the fascia fat and covered that one. So just to summarize. Okay, this was the case of a lateral sphenoid defect. You can see the part of the brain was. Yes, sir. So predictors of success are good preoperative workup, technically proficient with the sinus anatomy, and adequate exposure of the defect, and choosing the optimal procedure based on the location. And the ultimate goal is to achieve the normals in the intracranial pressure. So these are the main steps in dealing with this case. In conclusion, MRI with highly titulated images play sequence are useful. Early intervention is better. Endoscopic management is considered to be the current standard of care with a 90% success rate. Thank you very much.
Thank you, Dr. Ramesh, for the nice illustrative cases. Next, we'll move on to the next paper by Dr. Manas. Our initial experience of an exoscope in transspinal surgeries.
I think all through the morning you have listened to complicated lectures. This means I'll just tell the process of removing pituitary tumor in a simple case so that you don't have CSF leak and cause vascular damage. Means we are used to, how many of you still do microscopic pituitary? Can you please raise hand? Pituitary with microscope. Okay, very few people. Means I like that all of you learn microscopic pituitary also. Don't leave microscopic pituitary because that is the ground level from where you can grow. I'll tell our experience with Exoscope. Now Exoscope has been combined with Endoscope. That's what they're planning to do. With the Exoscope, the advantage means in addition to the ergonomic advantage of an endoscope, it's still better than endoscope for ergonomics, but the depth of field and 3D is far better than a pure endoscope. And the optical zoom also is far better. And you work with 3D, and so your orientation is like you get the advantage of microscope and advantage of endoscope also. But these are pros and cons of each. I'll not go into details, but this is how you stand. You use the glasses and look at the like with an endoscope, but then you you do not get tired. Like when you do with endoscope, somebody has to hold for you, or you have to hold yourself. But this is away from that. It doesn't occupy space in the nose, so you have more space to work. You don't have to do any mucosal, submucosal, or remove any mucosa, do an Haddad flap to overcome or enlarge the opening. We just cut the columella. So we preserve mucosa, but just cut columella. This is what we learned from a plastic surgeon. You cut columella below and then stitch it. So cosmetically not seen later, and you get a wide opening. So you straight away go to the septum, near the vomer, identify both the osteums, break the vomer, posterior part of the vomer, identify both osteum here and connect both the osteums, do sphenoidotomy, and you're there directly on the cellular floor within 2 minutes or 3 minutes or 5 minutes, whatever you tell. It's faster than an endoscope. And this is what the view you get. Means this is a 3D recording. That's why you see two pictures. And now this is the plenum is seen well. This is with the exoscope. Plenum is seen, and you can see the floor. The most important is take out the floor of the cella. If you remove the floor of the cella, the gland falls down, and then it is easier to remove. So the most important part of any surgery is take out the whole floor, whether you do with microscope, exoscope, or endoscope, and then leave a little bit of bone near the plenum, 1 or 2 millimeter, so that you'll have CSF leak. Most of the time, the CSF leak is at this place. And if you leave a little bit of bone and take out the floor, tumor falls down, you can take out the tumor. So this is the exposure with an exoscope. I don't think it's anything worse than an endoscope. And you have a lot of space around. You have 3D orientation, working bimanually, and with no help required from a resident or a surgeon or an ENT surgeon. Open the dura. We prefer to open the dura in a crisscross so that the flaps is based on both cavernous sinus on either side. Yeah. So we open the flap like crisscross, so the flaps are on each cavernous sinus, and the upper flap is towards the superior anterior cavernous sinus, and the lower flap is towards the inferior cavernous sinus. But then we saw today, means everybody has their own individual preference of opening. Somebody prefers down, somebody takes out the whole cellar dura. It's whatever you prefer. This is what we prefer, making a crisscross so that based on the cavernous sinus. And for removing tumor, the first part of the tumor is to remove the floor of the tumor. Remove the floor go along the floor as you remove the floor, and identify the first thing you will feel is the dorsum, base of the dorsum. As Dr. Prakashna presented that he goes to the clarinet, but if you follow the floor, you feel the dorsum and come from back to front. Take the ring curate, come from back to front. Do not remove the upper part at any point of time, though it will be bulging down. Then do alternately from the right and left side, go clockwise and anti-clockwise till the dome. The last part to be removed is the dome, because if you remove that dome first, you will have CSF leak, CSF damage. So the principle is not dissecting from top to bottom, but bottom to top. So because the dura, you follow the dura on the from the floor on the medial side on the cavernous sinus, and follow the dura on the diaphragm cell and go superiorly. So you can see here from floor, then on the lateral side, finally on the dome, again coming from back to front, not from front to back, not rolling from front to back. And as you do that, though it looks like that I'll damage the arachnoid, but I'll show you the end result. So I push it, go always from back to front. Because it has the exoscope has a better illumination 3D and magnification, the contrast between the gland and the tumor is very good. You can see here, the gland is seen clearly and the tumor. This is better than an endoscope, what I felt in my experience. And so always follow back to front. And this is what is arachnoid is seen. Slowly take out the tumor. If you follow from back to front, there's hardly any arachnoid will be damaged. Whether you do with exoscope, microscope, endoscope, most important thing is preserving the arachnoid. And 90% of the tumors do not need any extended approach. They can be done with a simple transsphenoidal approach. So, because working with the exoscope, you have clarity of image. You can see the gland clearly, you can see the arachnoid. And this I had a lot of questions to a lot of people who do not hesitate to devascularize the pituitary gland or cut the pituitary stalk. And I don't know what are the long-term consequences of devascularizing by inferior hypophyseal artery, devascularizing when you transpose. I had a lot of questions, but we'll have time in the dissection hall to ask the faculty. And this is the end. Then you pack with fat. So the quality is no inferior than an endoscope. Before I conclude, I'd like to invite you to the ISPN CME on July 4th and 6th at Hyderabad, and the spine meeting in September 19th and 22nd this year. Thank you for your attention.
Thank you, sir, for finishing well before time. And we have one extra talk which was missed from yesterday. And that is by Dr. K. Sunil Singh from Apollo Hospital, Lucknow. And he'll be speaking on endoscopic endonasal pituitary surgery, their experience.
So, good morning, and I thank the organizers, Dr. Ramesh and everyone else for the opportunity. So I'll just delve into this. Many advanced things have been done, but we are back to the pituitary surgeries, and that is the most common thing that most of us are doing. Objectives of the surgery: complete excision of the tumor with preservation of the normal pituitary gland. There should be no vascular damage or CSL peak as far as possible, and minimal nasal complications. Pre-op preparation, I think most of the things are covered already. Mainly, we need to take a decision on the need of vascular flaps, septoplasty, if that is to be done, turbinate resection, the size of the sphenoidotomy that has to be done, if we need to put in a lumbar drain, and the extent of the planned resection that ideally should be 100%, but sometimes you need to taper it down. The radiology that we need is the contrast MRI SELA and the CT-PNS, which are the most important radiological investigations, where we need to study the detailed anatomy of the tumor and its relations to the surrounding structures. We need special focus on the carotids and the other nasal structures that will be coming along the way, like the spurs, the DNS, if it is there, position of the midline, middle turbinate, and other things. So these are the MRI CT scans of different patients. As an illustrative case, we have a tumor here, moderate sized tumor within the cavity. So how do we go along with planning and execution of the surgery? So we need to decide on the side of the entry. Usually it's the right side here as far as possible. Hadar flap in such cases usually may not be needed because we don't plan a very large, it's not a very large tumor. Turbinate resection usually can be avoided for such cases. Posterior septectomy, a small needs to be done sometimes, and we would keep glue and Merosil and other things handy. So this is how we go about approaching this. Inspect the nasal contents, nasal structures, go behind, look at the anatomy that is there. This is into the nasopharynx, looking around, and then we go ahead with that. Because we are not planning a Hadar flap here, we would, and neither a turbinate resection. We go ahead with identifying the ostia, sphenoid ostia, and from there we can start enlarging the ostia for an anterior sphenoidotomy, and a little bit of the posterior septectomy can also be done. So we'll go ahead as we planned. We are just going ahead with enlarging the ostia for a sphenoidotomy. Remember that it's not a very large thing that we are planning. We can use a debrider, Carrison punches, and other instruments for that. And once we enter the sphenoid, then we can remove the septa with different instruments. Identify the sphenoid structures there. And the sella floor can be removed by drilling, by punches, and other things. So standard cruciate incision, as has been discussed earlier. And then to remove the tumor, as Dr. Manas had said, from below and the sides first, anterior part is the last. We can use suctions, ring curettes, different angled curettes for removal of the tumor. Cotton pledget can be used to, if the arachnoid bulges prematurely, then we can put a small pledget and push it upwards with the instrument to look below that. So after the tumor removal, pulsating arachnoid, no serious leak, the medial margins of the cavernous are also visualized and tumor is out. And after that, because of reconstruction, we did not plan a Hadar flap, so we just put in fat pack, glue, and some gel foam. And because there is no CSO leak also, we don't expect any problems there. Another illustrative case of a larger tumor, which is going into the suprasellar area as well. So same things, how do we make a decision? The Hadar flap, you would definitely need one in this case. So that's how we plan it. Turbinate resection may or may not be done depending on the various anatomies there. And glue, Merosil, posterior septectomy, all those decisions need to be taken, and then we plan it accordingly. So again, same steps, going inside, identifying nasal structures, looking lateral to the turbinate, and then we lateralize it. Then harvesting a Hadar flap by the incision, separate incision below, anteriorly, and above. The size of the Hadar flap can be tailored according to the size of the cellar opening that we are planning. So that is dissected from anterior to posteriorly. And that can, once it is pushed back up to the sphenoid lateral to the ostia, then it can be pushed down into the nasopharynx till it is needed. The posterior septectomy is also done. With different instruments, drills can be used for this part. It should be large sphenoidotomy as far as possible. Otherwise, instruments tend to clash with each other and they cause problems later on. So remove the mucosa from the cellar floor and then identify the different things and fill the cellar floor there. And once it's thinned out, then the cellar floor can be removed by punches or by different instruments there. Should drill and enlarge the cellar floor as far as the cavernous sinus and not definitely across that. Same incision by cruciate thing, and then removing the tumor with the sander thing. It's a soft tumor, could be easily removed with cuvettes and suction. Always below to above, posterior to anteriorly. And again, if there's any premature arachnoid bulging, then it can always be pushed away with the cotton pledget placed upwards. So the bulging was there, but because we had removed the tumor behind that, it was only the part that was remaining anteriorly that still needed removal. So those are all parts of the tumor that were anterior to the small arachnoid bulge that occurred earlier. And once that is out, then we can see the normal bulging, no tumor is remaining, the normal gland is visualized there. And luckily no CSF leak also. Using a cotton pledget to inspect all the crevices and corners, just to be sure that there is no tumor anywhere else. After that, fat packing and prepare with the Herard flap and glue is done. Another similar case was there. I think I'll just skip that because there's not trying to finish before time. So just to summarize that we should have a good clinical and radiological information before you proceed for any case. You should know your endoscopic anatomy and need to individualize the procedure you are doing to the individual case that is there. And always you should try to ensure that you have proper equipment and assistants to help you out. Thank you.
Thank you, Dr. Sunil, for finishing on time. I think we have gone beyond time quite a bit. So we close this session, and do we have a tea break now?
Thank you, ma'am. We'll go for a tea break and join for.
So
Already we are running short of time.
And then over to Ramesh. Thank you.
We would like to go to the dissection hall directly. Tea will come there and it's not to waste more time.
ఉందా వీడియో? హలో, చెక్ చెక్ చెక్. హలో, వస్తున్నానా? చెక్ చెక్ చెక్.
check, 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 check. Hello, check. Check. Check, check. Hello, check, check, check. Check. Check, 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 check. Hello, check, check. Check, check. మాట్లాడుతున్నాడు. Check, 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 check. వస్తుందా? Check, 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 check.
హలో, 1 2 చెక్ చెక్. వస్తున్నాను. ఓకే ఓకే చెక్. ఓకే.
Hello, check. Hello, check. 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 Hello, check. Hello, check.
Hello. The demonstration will start in the first table. So please go to your cadaver after the demonstration is over. Respective, the names are written in front of each table like last time, yesterday. So let the demonstration be over. You can do this. In between there will be a short lunch break, and after that also the cadaver is there. You can continue to practice till evening 5:30. So don't be in a hurry. First observe, then do.
Gaz Pislava. Let me see. Dissector. It's okay. So let us start with the endonasal endoscopic exposure of the orbit. So basically, you have to, the entire procedure is done in the middle meatus, that is lateral to the middle turbinate, in the lateral nasal wall. Okay. So I think middle turbinate has already been removed in this cadaver. So the first section you see, this is the middle turbinate, okay, which has been removed here. Let me see this side if there is middle turbinate present or not. I think here also removed. Okay. So there is no middle turbinate. So here is the middle turbinate. So what we do, we middleize the middle turbinate to widen the middle meatus. And the first structure you see here is this is the uncinate process. This uncinate process is only mobile structure. It has a free border. You can see here. So the first, there are 4 gates. One is uncinate process, number 1. Behind this you will get bulla ethmoidal. Bulla is nothing but anterior smart air cell. And behind that you will get this second gate. First gate is uncinate, second is bulla, third is ground lamella. Ground lamella is the part of the middle turbinate. Middle turbinate has 3 parts. Somebody spoke yesterday. Anterior part is the vertical attachment. Middle part is coronal plane. This middle part is the ground lamella or basal lamella. It forms a partition between the anterior smart air cell as well as the posterior smart air cell. This is third gate. And the fourth gate is anterior sphenoid wall. So once you open all these gates one by one from anterior to posterior, the entire medial wall lamina papilla will be in front of you. So आपके पास बैक बाइटर है, देखिए बैक बाइटर. बैक बाइटर ना ये नहीं है, कोई बात नहीं है. हाँ. So the uncinectomy can be done by 2 ways. One is entry gate, otherwise is retrograde. So if you take a dissector, just take it. This is the uncinate process. Make a incision like this. This will be anti-gate uncinectomy. Okay? Make an incision like this. This will be anti-grade. Alternatively, whatever ENT colleague does, they take another special instrument. This is known as backbiter, backbiting instrument, and just take it like this inside and engage it like this. Okay, and then punch it. This is known as retrograde uncinectomy.
retrograde. Okay? So I am doing this. I have to engage it and then just cut it. Okay? One more cut. This is required, anxiety is required for doing one very common procedure which our NT colleague does is endoscopic DCR, decrocystorenal, which is done in, there is chronic epiphora. We are not interested in that. So, I have shown you in, retrograde, then now integrate, both I am showing you. So just make a cut like this. Okay, the anxiety is done. Huh? So now you do you have seizure? टर्मिनेट पीछे दे दीजिए. कोई बात नहीं, अभी कोई पाइप से दे दीजिए. दिस इज सो इनफ. Just cut it. And then और ये पतला है हमारे पास, देखिए. So once you ball probe, do you have ball probe? So once you have removed ansenectomy, then you see the bulla. Here, this is the and in the lower part of the just behind the ansenate, you will see the maxillary air cell, maxillary sinus air cell opening. Okay, this is okay. So you have to enlarge it. I have shown in my presentation that you have to enlarge it so that after the surgery is over, there should not be any maxillary sinusitis. Otherwise, it will get blocked and there will be collection inside. So, after the procedure over or in between, just take a ball probe inside the opening and make a movement like this. Just fracture it. You will enlarge the maxillary sinus opening. Okay. So this we enter in the maxillary sinus. So this is and just remove this mucosa. You can debride it. Okay. So this procedure is must. Otherwise, patient will have later on maxillary sinusitis. So this is the bulla, bulla ethmoidal. This is the largest interstitial air cell. So what I have shown in my presentation is you can open from anterior side here. Otherwise, there is a retrobullar recess here, because middle terminate has been cut, you are not visible everything. So otherwise, you just take a ball probe here, goes inside and just fractures you anteriorly. Okay, so whole bulla will be coming out. So once you remove the bulla, things are very much stiff. Just go behind it and fracture it. This is retrobullar recess, fracture interiorly. Everything will come out. And then take it out. So after that, somewhere you will get this, because the middle terminate is gone, so there will be attachment from middle terminate up to the lateral wall of the nose, that is lamina papyracea. That is called ground lamella. Okay, so you have to just need to open it and enter the posterior ethmoidal cells. These are the posterior ethmoidal cells. Actually, superior terminate has also gone. Otherwise, you will identify the important landmark superior terminate, and everything lateral to superior terminate you will get. That is the posterior ethmoidal cell. So remove everything lateral to that. The sections seem to be blocked. And this all you see is the lamina papyracea. Okay, this everything. Okay. So once you remove all the mucosa and everything, actually I am making a window here so that I can go manage the opposite side. Okay. Okay, this is lamina papyracea. This is lamina papyracea. Okay. So this is very thin bone. Just take it out. You are already seeing the periorbita. Okay. Just to confirm this is periorbita. Just push the globe. You see, I am pushing the globe. When the tumor is inside, the assistant pushes the globe. The same time you are dissecting, the assistant pushes the digital pressure over the globe. Precisely speaking, not over the globe, towards the tumor. Like tumor is present in the superior part, he pushes the superior part. In the middle part, pushes the middle part. In the inferior part, he pushes the inferior part. So that the tumor gets pushed inside. So there is no need to do anything. It's very small maneuver. Tumor gets pushed inside. You dissect from the inside, do traction, counter traction, tumor comes out. So once you have dissected identified the periorbita, you open the periorbita. You see the periorbital fat. And after this, then you have to do binostril. When uninostril is not possible, so now dissect out the fat, identify the medial rectus muscle. Do you see the muscle? This is muscle. Okay. Now hook up the middle rectus muscle up. You hooked up the muscle. This is the muscle. muscle fibers, lift the muscle up, then you see the optic nerve. Okay. So you have to work between the medial rectus as well as the inferior rectus. Okay. Many times you need to do optic nerve decompression for traumatic optic nerve injury or optic nerve sheath fenestration. So in that situation, you and if there is OCR or optic nerve protuberance is seen, that's good. Many times you are not able to see these landmarks. So it becomes difficult for you to identify where the optic nerve is. So what to be done? This lamina papyracea, this period, it converges like a triangle and just follow it. Okay, keep on removing the lamina papyracea posterior part, and at some place it will it will converge here. Let me show you. You see, this is the optic nerve. Okay, so where it is converged, this place will be optic nerve. Okay, so just drill it out. Sorry, fenestration. Yeah. You remove this part, but many times, like here, some prominence is seen, so it will easy. Other many times, this landmark is not visible. Are there multi-septa is present? You don't have navigation. Many places not available. So how to identify that time? You follow this. You find out lamina papyracea. How I did it, and then after just remove it, and it will take you to the optic nerve itself. You just see here. अरे भाई ये देखिए ना, this whole everything is converging here only ना, here from here side it is converging here only. Just see, this is converging here only na, this is remaining part of the bone. Okay, it's converging here. So yeah, this part, you see, because the optic is a cone shaped structure, it converges there, and the end there will be the optic canal. So just drill here. Do we have drill? Drill भैया, drill है? drill आइए भाई. You see, the tumor decide where the approach. If the tumor is behind the globe, then you have to do endonasal in the predominantly middle part. If tumor is located predominantly in the middle part of the orbit, in the medial part, okay, this is one condition where you can go through nose. Another thing is that the tumor should be behind the globe. It should not be anterior or above the globe. Many times the tumor is present in the anterior part and just above the globe. The globe is shifted down. Okay, so at that situation, you need not to go through nose because it's much anterior. If you go nose, it will go behind. So I often prefer transpalpebral approach. Transpalpebral, just put incision here, it will come out. Similarly, if the tumor is present in the inferior part, so I often use transconjunctival approach with our ophthalmology colleague. If the tumor is in more predominantly in the lateral part, I do lateral arbitratomy, then take it out. Okay, so depending on where the tumor is, you have to decide what approach should be taken. अब भाई drill on कर दो. Hello, drill. If you are using drill, you have to be very careful. Remember three things. There is something known as a moving part of the drill. This moving part of drill is should be under vision. Otherwise, anytime you may hit it. Suppose this is like this. Although I am using different nostrils, but still, if you like this, if the complete moving part is not under vision, the moving it may damage your endoscope. Okay. The other thing, paintbrush technique like this. Okay, the technique is paintbrush. And the third thing, first stop the drill, then take it out. Don't take out moving drill. Otherwise you injure the endoscope. कहाँ गया रह गया लगता है okay, so keep the moving part of drill under vision always, and paintbrush technique. Usually I take suction in my other hand, but here it's not possible, so I am. Can you hold the scope for me? Holding the scope like this. Do like this, hold like, okay? And with the hand, you have to take out all the wires with you, okay? Hold the camera head, not the endoscope. You can come closer. Stand like this, leg apart. Are you comfortable? सेक्शन तो भाई ब्लैक है, थोड़ा बड़ा सेक्शन है क्या? मोटा मोटा है भैया? कोई बात नहीं, जो है वही लो भाई. The area of interest should be in the center. See, paintbrush technique. Huh? Make it excel. It has been done, I think. Slide like me. पतला डिसेक्टर कहाँ गया? बाल पर कुछ दे दीजिए. हाँ, इट्स ओके. थैंक यू. You see, I think some bone has been drilled, some part of bone is left behind. So you have to drill the complete canal. In case of traumatic abdominal injury, you might see some fracture. You have to take out the fracture. Okay? You drill out something. And in case of optic nerve sheath fenestration, in case of BIH, you completely drill out the optic canal, and then after make an incision. Incision over the optic nerve, not in the inferior part, because in the inferior part the ophthalmic artery is there. So in the superior part, हमारे पास सिकल नाइफ है, सिकल नाइफ कोई नहीं है? हाँ, सिकल नाइफ दीजिए. So make an incision in the superior part, okay, like this. And once you make the incision, and then after CSF comes out, okay, CSF starts coming out like this, and then the procedure is over. Just put some amount of fat here and put a lumbar in. Okay, so this completes the exposure of the orbit as well as the optic canal. No, Miss, here too medial. Not only till the optic canal. Optic canal. Not much. Close, just put PET. No reconstruction, nothing is required. Okay, any question, anybody? If you use a dissector, let me show on this side. I think this is the uncinate process. Okay. This is the uncinate process. If you just do like this, this is thin bone. Okay. Just do like this, and make a cut here in the lower part, make a cut in the upper part, and take it out. Okay, like I have made it, I just removed it. Okay, so this is an antegrade, and if you use backbiter, that is known as retrograde. And then after you see this bulla, okay, so behind this, just behind the bulla, you will see a space, a small recess is there. Just take your ball probe, put in the recess, and just entirely fracture it. The whole bulla will come out, and immediately you will see the ground labella. Just see here. Then take it. So this ancestry has been done. This is bulla. Somewhere here, you see, this is under. This is the recess. Just take it and just pull it entirely. The whole bulla will come out. And you see, this is the remnant of the middle turbinate, which is going in the lamina papyracea. You open this, you will enter the posterior thymid air cell. Okay. So this is the posterior thymid air cell. Because superior turbinate already cut. Otherwise, you somehow find here the superior turbinate also. So remember these 4 gates. You have to open each one by one, and the entire orbit will be in front of you. It doesn't take much time. Okay. Thank you. Only, it's not removal. I don't remove it. It's not required. Don't remove anything unnecessarily. If there is problem, you can remove it. Okay. Thank you. Yeah. Thank you. In continuity, audible to everybody. If you are not audible, please tell me. And yeah, that's okay. It's okay. So you are seeing some impressions and some structures that were told to you yesterday. So you are seeing the impression of the paraclival carotid artery here, and you are seeing the base of the sella with the pituitary gland here. So this is the ICA, which you call your paraclival ICA or your cavernous ICA here. And this goes posteriorly and then curves like this to form the cavernous ICA or the genu of the ICA here. Sound is not coming or picture is not coming? You can see the impression of the optic nerve here. And our approach will be directed towards this side, which is going to be the lateral part of the ICA, the cavernous sinus, the Meckel's cave, and the center for this is this particular part that is called the pterygoid wedge. So, can you hold the scope for me? So, no, this is okay. So the first part of your approach starts with what we do on the lateral wall of the nose. So sir has already explained about all the structures that lie on the lateral wall. and this patient has had a turbinectomy and uncinectomy. So somewhere here you will encounter an opening which is the ostium of the maxillary sinus that has already been opened. You have a backbiter? Backbiter. Maxillary sinus, maxillary sinus. So when you open, so you can use this, you can use a debrider, you can use many different instruments to open into the maxillary sinus. So when you do a maxillary antrostomy, it takes you to the posterior wall of the maxillary sinus. Just hold those. No, dissected, cotyle. No, cotyle, no, the dissector, cotyle dissector. Cotyle or a double ender or a periosteum elevator. This you can take, I don't want this. Yeah, that. So, you are now seeing the posterior wall of the maxillary sinus here. Okay. Do you have a bigger suction? Do you have a bigger suction? No, wider suction, because there is this collection. No, this is. No problem. Even if you don't have it, I can manage. No issues. So, if you have a bigger suction, it drains things faster, but I think you can manage with this. So, I'm basically going to take out all this mucosa from here so that you can quickly see the. Normally, when you have an instrument like a debrider or a through cut, it works much faster. You have a through cut? You have a through cut. And is there a board on which I can stand? Is there a board on which I can stand? Something on which I can stand? Footstool or something like that? Something on which I can stand. Upcut. So basically this is opening the ostium nicely. And once you open the maxillary sinus, you start to see the posterior wall of the maxillary sinus. That's the important structure that you want to identify. So, No, reverse will become too high. It will become so high that So generally if it is higher, it's more ergonomic. The chances that you will develop, it's so high now. Anyway, so once you've cleared this tissue from the maxillary sinus, you start to see the posterior wall of the maxillary sinus. And this is now you can appreciate the posterior wall of the maxillary sinus here. So this is the first step of your procedure. The second step is to identify the ostium of the sphenopalatine artery or the sphenopalatine foramen. So one of the landmarks is that once you've opened up the maxillary ostium, you can elevate this mucosa that lies on the lateral aspect of the maxillary sinus. When you elevate this further, you come to a small elevation of bone, which you can start to appreciate now. Can you start to see this? So this is the sphenopalatine foramen, and the sphenopalatine artery comes out of this particular foramen. So in the sphenopalatine foramen, upcut. In the sphenopalatine foramen, your vascular structures lie anteriorly and your neural structures, that is the pterygopalatine ganglion, lies posteriorly. So you can slowly take off the bone here, and it can be taken off laterally till you approach the infraorbital nerve. Whether you want to go that far depends upon the indication that you're going to be operating for. But you can start to slowly clear this area, and the idea is that you need to isolate the sphenopalatine artery. Now you should remember that sphenopalatine artery is a direct branch of the internal maxillary artery. And because it is a direct branch of the internal maxillary artery, sometimes it can be quite large. So again, it can bleed. So identify it and then coagulate it. So you can see the foramen very clearly. Can you appreciate the foramen there? This is the sphenopalatine foramen, and sphenopalatine.
Can we lower your mask as voice?
Yeah, sure. Am I audible clearly? Okay. So this is the sphenopalatine foramen, and you can slowly open the sphenopalatine foramen. So when you open this, posterior to this, you see one shiny structure. That is the pterygopalatine ganglion, and it is shiny because it is covered by periosteum. Okay. So when you open this laterally, you will even encounter some amount of fat that lies in the pterygopalatine ganglion. And you can open this really posteriorly. If you do a medial maxillectomy, you can open so clearly that you can then ligate the internal maxillary artery. So sometimes that is also needed in some procedures like JNA and all. But can you appreciate this shiny structure here? Yeah. So that is the pterygopalatine ganglion. Now, who can tell me what are the structures that come out of the pterygopalatine ganglion? I'm just asking you these questions to be sure that nobody is sleeping. I can be certain that some of us have learned to sleep while standing also. Lesser palatine, descending palatine. Nerve of the, it's a Vidian nerve, no? So you have three nerves. One is the Vidian nerve, which goes anteriorly. So that proceeds from this direction, starting here towards the internal carotid artery. So it goes away from you. You have the descending palatine nerve that goes into the maxilla. So that goes inferiorly. And you have V2, that is the maxillary nerve that is coming out of the foramen rotundum, which gives some branches to the pterygopalatine ganglion, then continues as the infraorbital nerve. So it does not actually confluence with the pterygopalatine ganglion. Instead, it gives some fibers, but the nerve itself continues superiorly as the infraorbital nerve. So the infraorbital foramen lies in the roof of the maxilla. So for some other indication when we dissect, we'll probably be able to see, but here I'm not going to be dissecting that laterally. The priority is going to be for dissecting the pterygoid plate today. So anyway, so now this can be opened superiorly. With a drill it becomes much more easier because sometimes this piece of bone is harder, but give me some time. So you can start to see the pterygoid ganglion very clearly. Pterygopalatine ganglion very clearly. I'm sorry?
This is the same approach for the pterygopalatine fossa tumors.
Pterygopalatine?
Fossa tumors.
Pterygopalatine fossa tumors, see, you can. So basically, what this is an approach, what the transpterygoid approach takes you to the lateral part of the sphenoid sinus. It also gives you access into the infratemporal fossa. It gives you access to the pterygopalatine fossa. And it gives you access to the jugular foramen when you want to go down to the petrous apex and then further down into the jugular foramen. So these are the various areas that you can reach by going along this particular path. So now you can appreciate the pterygopalatine ganglion here, and you can appreciate the sphenopalatine artery there. Can you see that? So this has already, part of that mucosa has already been upcut. But otherwise what happens is that you can isolate the sphenopalatine artery there, and then you can coagulate it. Okay. And depending upon your requirement, you can take this bone removal further. You can expose the ganglion nicely further. Now superiorly, you can take this opening till you see the foramen rotundum, which is a very important landmark when you're doing skull base surgery in the cavernous sinus. Okay. So the next step is to isolate the sphenopalatine artery. So you can comfortably see where it is. Can you give me some knife or something of that sort? That knife was there, no? One sickle knife was there. So this is the sphenopalatine artery here. Can you see that? And this can be then coagulated. So as it comes out here, you can coagulate it. Okay. Now, the next step of your dissection, Cottle. The next step of your dissection is to then expose the pterygoid wedge. So here in the midline, you have the sphenoid rostrum. See, this is the keel of the sphenoid that you typically see for all your midline procedures. And this is the pterygoid wedge here laterally that gives attachment to the pterygoid process. So this is the part here. Now we need to drill this, move the pterygopalatine ganglion laterally, and also be able to come to the lateral recess of the sphenoid sinus. Okay. So for that, can you show me the drill? Drill foot is where? Can you put the foot up here on the can you hold the scope for me? Okay, hold it here. Can you give me that big section? Because you will have a lot of bone test coming, so bigger sections are much better in the sense that they don't get blocked. And also this type of Ferguson section is very useful because the curvature. So you can come back a little bit, you can hold it here. This is okay. Can you bring this down? No, this second level. Okay, fine. Forget about it. Just take it off. Take off the footstool. So we start by drilling on this particular part. Come back so that they can see. So you can push this fold of mucosa down and drill along the pterygoid. Now what has happened is that the bone here is quite thin, so I'm basically thick, so I'm thinning it down and at some point retract the median nerve to cut it so that the entire pterygopalatine ganglion can be retracted in one direction.
All these things you are doing with the middle turbinate in situ.
I'm sorry?
We are not.
So suppose you are doing a fresh case, no, sometimes it's very difficult to do this part if you have the middle turbinate sitting there. And if I'm doing a trans-pterygoid, then ideally I'll prefer to take out the middle turbinate on that side. Because if you notice, no, you are utilizing one extra cavity on the right side, which is created by the maxilla. And you need space also, no, because your endoscope has to come in, your instruments have to come in, and you also have to bring your own instruments for dissection in this plane. So it's much easier to have. Can you give irrigation? Put a nozzle on that. Put a nozzle on that. Put some syringe or something, no? No, put some syringe or something on that, no? No, syringe. Put some needle or something which can be used. So see, by drilling this much itself, you might have started to see that the visualization of this part of the internal carotid artery has increased. So this bridge of bone here prevents you from being able to come to this part. But the moment you've drilled it, you're already able to see this.
So systematically, I'll show you how you can improve visualization of the lateral recess of the sphenoid sinus, and then take your dissection further to expose the internal carotid artery. Back better, back better. Back better, back better. Wait, do you have a longer drill attachment? Boss, do you have a longer attachment? Transnasal burr you have? You have? No, you have the transnasal burr which is slightly longer. Wash. So, I'm now drilling the lateralmost part of the sphenoid, and you can start to see the area that you will have to visualize when you want to do a lateral recess leak. That is the lateral wall. So you can now appreciate the increased exposure that you have for the lateral wall of the sphenoid sinus. This is where you will have to work when you're doing CSF leaks. So there are 2 or 3 impressions that you have on the lateral wall of the sphenoid sinus. One of them is called the maxillary strut. The maxillary strut is a particularly important landmark for identifying the lower part of the maxillary nerve, and that is also called the entrance into the Meckel's cave. So if you want to open the Meckel's cave when you are doing a trans-pterygoid approach, you want to open it closer to the maxillary nerve. That is far away from the extraocular nerve, especially the 6th nerve, that can be pushed anteriorly when you are doing a surgery for the Meckel's cave, especially for tumors like trigeminal schwannomas. So at this point of time, you can start to see 20 minutes. No, 15 minutes. I'll be done. I'll be done. So I had this is actually slightly short, no. So I'm having to. When you go from one nostril to the other end, you need a slightly longer bit, and here the shaft is so wide, no, that it obstructs the view. So it's not a problem, but it takes a little bit more time in the sense that. So now, like I was telling you earlier, no, whatever we try is always trying to avoid drilling on the ICA itself. And what happens is that some of the bone on the lateral aspect of the ICA is thinner. So you can actually drill on either sides of the ICA, and then you can flick that bone off. And that makes surgery a little bit safer in the sense that you will not have to drill on the carotid artery directly. Okay. So, for example, when you're seeing the clivus here, so again, mobilization of the ICA starts by drilling on either sides. Cottle. You had one transnasal bit, no, that was slightly longer. One transnasal burr was there, no, that was longer than this one. You don't have that. Hold this. No, this is actually I'm drilling higher just to clear off that bony septation also. So some parts are difficult to break with upcut. Once you thin it out, no, it becomes much easier to break with upcut. So basically, this part of bone is slightly harder. So I'm basically drilling it off. And all of these are going to take you towards the, or increase the view that you get for the lateral aspect. So the center of your approach, every, like for example, when you're doing an extended approach, the sella is the center of your approach, and all your exposure is done either anterior or inferior to the sella. So you open anteriorly onto the tuberculum, you open anteriorly or inferiorly onto the clivus, and you extend your approach. Here, the exposure is centered around the foramen lacerum. So you want to open into either Meckel's cave, or you want to open into wash. So also when you are drilling real time or in cadavers, when you wash, the bone remains moist, and moist bone drills better. It doesn't generate as much heat. So ideally in clinical settings also, you will want to keep irrigation going during a surgical procedure. Or if you don't have that, at least keep irrigating intermittently, so that the amount of heat that you transfer to your this is minimized. Come back a little bit. So basically this is bone that I need to remove to identify the pterygoid. So you can appreciate this. This is the entire wedge of bone that has to go. And you're trying to lateralize the pterygoid and the sphenopalatine ganglion so that you can get a better view of that particular place. Now somewhere here, as we transpose this, you will also identify the Vidian nerve. So that will be the next step of your exposure. And by identifying the Vidian nerve and cutting it, you will be able to move the pterygopalatine ganglion towards one side. So now, this is the mucosal fold that I have mobilized inferiorly. Okay, this is the rostrum, and you can appreciate the pterygoid wedge here. Can you see that? This is the pterygoid wedge, and somewhere here you will have the Vidian canal. We'll come to that part. Now inferiorly here, in this particular region, you have the eustachian tube. So you can mobilize this inferiorly till you come to the eustachian tube. And you can, when you drill this inferiorly at the back, you will also encounter the cartilage of the eustachian tube. No, you will see the foramen. I'll show you the foramen. See, what happens is, in some cases the bone is thin, it becomes easier to use the upcut and do the whole thing. Here the bone is a little thicker, so I'm drilling so that I can at least keep orienting myself also to anatomical landmarks. That is the important thing. But before surgery, you should, have seen the scan. You should have read the MRI to sometimes see the extent of nematization. In some patients, you can have a large lateral recess of the sphenoid sinus, and in those cases, the Vidian canal lies in the nematization. So it's much more easier to, see and trace. And when you're drilling on the vessel, when you're drilling close to the ICA, you drill along the line of the vessel. Prefer to drill along the line of the vessel and not across the line of the vessel. Here you drill along the C shapes of the cavernous sinus on the right side and stay as far as possible lateral to the cavernous sinus and lateral to the ICA. So as you continue your drilling further, what will happen is that the bone will become much thinner and you will be much more prepared to knock the bone off using either a dissector or the process of your upcut. So the upcut also can be used as a dissecting instrument, and the footplate of the upcut can be used to, you keep thinning bone out. The undersurface of the sella is a safe place to drill because there is no major structure there, and it also lets you see where the inferior intercavernous sinus is.
Sir, it is possible to lesion the ganglion.
I'm sorry?
Ganglion through endoscopic.
Pterygopalatine ganglion, huh? What?
Trigeminal ganglion.
Huh.
Endoscopically.
Trigeminal ganglion is different from the pterygopalatine ganglion. Trigeminal ganglion sits in the Meckel's cave.
Yes, sir.
So suppose for example you have a Meckel's cave schwannoma, then you can do that endonasally. You however have to see the relationship of the ganglion with the ICA at that point of time, because some of those tumors lie anterior to the ICA. Those are very good indications for the endonasal route. However, some of them lie posterior to the ICA, and they are not very good indications for the endonasal route. It's a different anatomical entity, that's in the Meckel's cave. So Meckel's cave I will show you now. I'll show you the Meckel's cave now. Here you will be able to not only identify Meckel's cave, you'll also be able to see the Vidian nerve. I'm sorry, maxillary nerve. So here now you are seeing the periosteum that covers the Meckel's cave and the cavernous sinus lateral compartment. And this strut of bone on the inferior aspect of the maxillary nerve is called the maxillary strut. So once you mobilize the maxillary strut, you are able to entirely free up the maxillary nerve.
Radiofrequency ablation can be done endoscopically.
So it's a very direct percutaneous procedure, no? It's a very direct percutaneous procedure where you do not enter into the sinonasal cavity. See, one of the problems with doing this procedure through the nose is that you have to go into the cistern and you are then making a clean procedure, a clean contaminated procedure. So I don't know whether you want to do it like that, but there is another procedure which is called the blocking the pterygopalatine ganglion, which can be directly done, which is already being done by some people, because that is in the sinonasal cavity. Wash.
So this piece of bone that you
So this is the bone that is situated on the surface of the cavernous sinus and the Meckel's cave. So you can see this. No, so this is the cavernous sinus. I'm just clearing the bone off. So basically, like I said, no, I'm drilling on either sides of the ICA. Find it much more comfortable to do, but at any point of time, no, skeletonizing the ICA is a strenuous process. It's a tedious process. It's something that requires a great deal of concentration, and it's not something that should be done casually. So you have to. Currently, usually all your drills, will have a narrower shaft, and with a narrower shaft, it becomes much more convenient to see what you're drilling. Cottle. Wash. So now I'm chipping off the floor of the cellar here, and some more bone. So there are pieces here of bone that can be quite dense, whereas some parts of bone can be quite thin. Okay. Wash. Cottle. So you can see that this bone chip has now become loose. Okay, you can now slowly mobilize this bone chip without actually having to drill on that. But upcut to me.
Upcut.
So the footplate of the this is used as a dissector rather than to cut it like this. You just put it underneath and slowly nibble it off. So by doing that much, you can suddenly see that the lateral compartment of the cavernous sinus and the Meckel's cave has now come into view, and this part of bone here can be quite easily chipped off. See, you can easily chip it off like this. So now you can appreciate the cavernous sinus laterally. Wash. So now you are seeing the cavernous sinus laterally here. Upcut, 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 upcut. Basically what I'm trying to do is to chip off whatever thin bone is available so that I can trace V2 up to foramen rotundum. So there is an anterior point at which the maxillary nerve comes out of the cavernous sinus. So this is the orbit that sir had shown earlier, and this is the part where you have the superior orbital fissure, where the, can you appreciate this? So you come to the superior orbital fissure. So these are all structures that lie very close to each other. Okay. Now, as I come more anteriorly from here, if I come more anteriorly from here, Cottle, you can see this is the pterygopalatine ganglion that I showed you, and this is V2. Okay. And this is the lateral compartment of the cavernous sinus. So maxillary nerve comes like this into the pterygopalatine ganglion. So now you want to see the third component that was described, that is the Vidian canal. Wash. So here now you can, so sometimes what happens is that this part where you're dissecting now, there are two vessels that are seen. One is the sphenopalatine artery that I told you about earlier. So you can appreciate the Vidian nerve. This is the Vidian canal. This is the Vidian canal. Okay, so the Vidian nerve goes like this towards the genu of the ICA anteriorly. So now we're going to drill along that. But you also encounter one other vessel there. Can you tell me the name of that? It's the palatovaginal artery. So that passes along the floor of the cella, of the sphenoid, and then goes below the rostrum and enters into the sinonasal cavity. So we'll drill in this particular part. Palatovaginal artery. Huh? Can you give me a hook or something? Irrigation? Let's clean this. Clean. It's okay. Just hold it like that. Yeah, good. Come in. So, this is the pterygopalatine ganglion, and you can see the Vidian canal here. And we are now going to be drilling in this direction on the inferior aspect of the canal, basically to take us to the foramen lacerum. So there is also another structure that you need to know about, which is called the pterygosphenoidal fissure. So you basically are drilling with the pterygoid on one side, the sphenoid on the other side. So you have a rim of tissue that is a soft tissue condensate that forms between these parts of bone. It is called the pterygosphenoidal fissure. So generally, the pterygosphenoidal fissure also leads you to the foramen lacerum only, but as a landmark, I think it is much better to follow the Vidian nerve. It's a much more reliable and a easier landmark to follow. here you'll also have to drill on the middle aspect where you have the clivus. When you come towards the carotid artery, when you come towards the carotid artery, at the level of foramen lacerum, you have a process of bone. It is called the lingual process. Okay, and lingual process gives attachment to the petrolingual ligament. And you all know that the petrolingual ligament is the ligament at which the cavernous sinus, the carotid artery transitions from the laceral segment to the cavernous segment, and it's a point that you can identify on DSA also, isn't it? So basically what I'm trying to tell you is that each of these segments has its own anatomical correlate also. It is not that they are just hypothetical structures. They are structures that you should know about. You might see them, you may not see them, but they are structures that are there. Sometimes when you're doing cadavers, you don't see everything that you want to see, and that also is a reality. Sometimes because of the way the cadaver is prepared and all those things, there are certain structures that you may not be able to see. That's okay. The point is to at least know what is where and how it is to be identified. So please feel free to ask me anything that you want to ask, because we are nearly going to finish the exposure of the ICA here, and anything you want to ask me, please feel free to ask me.
So how do you open the anterior cavernous sinus over here?
Inferior cavernous sinus, how do I manage?
No, bleeding we manage by
So bleeding is managed using flow seal. What you can do is you can even crush gel foam on table, and you can use a syringe to inject gel foam if you are comfortable making that mix. I mean, you have to make sure that it is soft enough to be irrigated. But that also is very useful, and you can use a lot of gel foam, and gel foam is your primary this for managing your bleeding. So this has brought you to the foramen lacerum. Okay, so this is the entire segment of the ICA that has been skeletonized. Now I think we'll close up, wash. I'll just show you one more thing before we close, and that is the relationship of the middle cavernous sinus wall. So can you give me that knife, that hook knife? Then you can go on and do this on the cadaver that you have, and try to go structure by structure, so that you are able to appreciate all these things that you read about. You look for them and try to make out what is where. So you can now see this is the lateral compartment of the cavernous sinus, this is the Meckel's cave, this is the foramen lacerum, this is the segment of the ICA that I'll show you. Can you show me the knife? No, there is a knife, sickle knife, Wash. There is a sickle knife. You had given me that knife earlier, no? Kahan chala gaya? It's not on the table. If it's on some other table also, it was there only. Hook, anything, any ball hook, something that can cut. Okay, thank you, no problem. So, for opening the anterior intercavernous sinus, generally, opening the cavernous sinus, normally we choose this part where the inferior intercavernous sinus confluences with the cavernous sinus proper. This is because there is a small venous channel here, venous lake here, which separates it from the ICA. So when you do that, inferiorly, you will be able to encounter some structures. Those are the inferior paracellular ligaments, and I'll just show them to you in a minute. Wash. Sir, this will take only 1 minute. Just don't remove this and then I'll, or if you want, I can stop, no problem. Okay.
Whatever you have seen, you can start doing it, the orbital part and drilling.
Carry on. I think important.
Will be available on your tables to help you out.
When you do this, no, you come into this space where you have a gap between the.
This is the posterior genu, sir.
I'm sorry?
This is near the posterior genu only.
No, posterior genu we will not reach. Still at the anterior part.
Anterior part.
But I have just opened the cavernous sinus and I'm showing the inferior paracellular ligaments here. You can see the surface of the ICA that has been separated. And can you appreciate these ligaments there?
Yeah.
So those are the inferior paracellular ligaments. Exactly what you saw in the top. When you move these paracellular ligaments, no, it's okay. I think sir wants you to start.
I just want to show the paracellular ligaments.
Hold it. I'm happy to show you. Show. So come closer. You can see the internal carotid artery here.
Yes, sir.
You can open these paracellular ligaments. These are very flimsy ligaments. So you can come in. So when you open these, you will come to the structure here, which is the carotidoclinoidal ligament. It attaches between the carotid and the clinoidal segment of the ICA. And here again you can keep moving the pituitary gland towards one side.
The inferior superficial artery.
Yeah. So you come anteriorly, come further. And when you go posteriorly here, you will see the clinoid process. Cotyle. Or a dissector is also okay. Small dissector is also okay. Yeah, that's also perfect. I'll show you. Inferior hypophyseal also, I'll show you now. So once you've done this, you come to this part. And then, see, the important thing to understand is that you have the internal carotid artery here. Internal carotid artery is here. This is the ICA. The wall of the ICA. And the course of the ICA goes posteriorly. So it is not that the ICA is dead straight. Hold it up like this. This is so that there is not fighting with each other for space. Then go posteriorly. Immobilize this ICA. Come forward. Come forward. This is the pituitary gland which you are moving towards one side. And yeah, interdural. So this is inter. You're going between two layers of dura. And you pick it up like this. So, can you see the superior hypophyseal artery at the back? Come close. Come close. So, the horizontal segment of the ICA. And can you appreciate some vessels there? So sometimes you will have long, slender superior hypophyseal arteries. This is the posterior clinoid. clinoid, posterior clinoid. And now your pituitary gland has been separated. This is the ICA, and this is the further posteriorly.
Here should be inferior artery.
No, now if you move this down, you will see the third nerve that comes from the lateral aspect, and it enters into the roof of the cavernous sinus. So if I move this laterally, I cut this posteriorly, you can see that. That is the ICA, this is the ICA.
Communicating
This is the ICA. But as I go posteriorly, here, the roof of the cavernous sinus.
Anterior process.
So this is the space that is lateral to the. You'll find the third nerve there, and with more bone mobilization, maybe you'll be able to see third nerve come into the cavernous sinus. Anyway, that part we can do some other time.
Transposition, the removal of the exposure of the entire ICA is necessary always.
If you don't at least mobilize the upper part of the ICA, you will not find a gap to move the pituitary towards one side, because you have to see the proximal part. That is very important. Tell. See, third nerve will always. Can you just detach this?
Hello. Request everyone to come here for 5 minutes. Hello, all participants, delegates. Come here for 5 minutes. Be seated for 5 minutes here. Ramesh, ekkada babu? So we had officially planned a valedictory in the auditorium, but I thought that everyone is here only, so that people can continue with the dissection and will not disturb them. Most of them have come for a hands-on, so the hands-on should continue. So we thought that we'll finish the valedictory here only. So first of all, a big round of applause to Ramesh. He did a fantastic job in organizing. The important thing was adequate time in the lab, good amount of lectures, and the pre-series which he ran for 3 days. That was also very helpful. A lot of feedback came, but it was a lot of helpful for everyone actually. And
thank you, sir. Thank you, sir. Thank you, everyone. It would not have been so good if no one was participating. It was whenever I called anyone, they were ready at even the night, 11 o'clock, 12 o'clock, even the seniors, starting from Dr. Ramesh Tigla sir, Subodh sir, Manas sir. I know what the way it went through since last 3 months, calling everyone personally, speaking to them, please do join. I really, when I called the seniors, Dandapani sir, Avdesh sir, Krishna Prabhu sir, when I said, oh, whatever you want, you tell na. Why are you worried? Aapko kya chahiye? How did you plan? Prakash Nair sir, how did you plan? I call them, sir, what instruments are required? You don't worry, all the small things will take care. They were ready. I told Avdesh sir, you'll have 2 topics. Then again told, sir, we are not able to fit in. Both are almost similar. Can I change it to one? Oh, why are you worried? You just tell what is. I didn't expect. They're so kind enough for me. Then everyone who has joined, and they are so showed interest to present, and even the Kamineni and the OT faculty, everyone, including my residents and Dr. Shiva who has joined us, everyone played a part in this. And I should tell, you should not miss Kiran from CMC. He helped a lot. How much I have seen outside, you seen. I was just dumping my responsibility on him. You do that, I don't know. He was very good in taking my responsibility off outside, including the pharma people who helped us in the call stores, Metronics, Striker, everyone joined us to make this happen. Thanks a lot. We will, just to announce that we will form one of the good and young endoscopic skull-based group in the city. So start dissecting one of the cadaver, form a series of, slowly it will form a series of, so that by the next 4 or 5 years, we should be able to do all those things which I have seen today. Thank you.
the first challenge for him was getting a date actually. This program is getting postponed for last 6 months actually. He's been trying to do it for last 6 months, but one conference after one month, and he being relatively junior in the neurosurgical faculty, everyone, no, you can't do it in this thing. He postponed it. So that kept on happening, but he stood its stand and it did it. We would like to have some feedbacks from the delegate or the faculty. If you want any changes in the format system and how was it. Any one of the delegate or faculty, delegates, anyone has anything to say? Anybody for any feedback? No, everything is bad.
I'm Dr. Nagarjun from Bangalore. So to start with, when they announced, I was like, I know very few people in Hyderabad, but I'm not able to make out anybody's face, name and all. I was also hesitant. But definitely, if I had not joined and attended, I would have definitely regretted. I think it's given me a lot of confidence. Maybe I'll go back, and most of my cases I'm starting as endoscopy and converting to microscopy or put a speculum and then continue on endoscopy is what stage I'm in. I think definitely after this I'll be able to do, and also extended definitely gave me a eye-opener to what all we can do and what all to look for, understand and everything. Definitely it's been a good workshop. And most important is adequate time for the hands-on and pre-preparation, that these things you have to know. All those webinars were definitely important, even though it was a little difficult to attend every day, but still the recordings and the material given, everything was good. Definitely the time allotted, the patience shown, and the interest taken was a commendable job by Dr. Ramesh and team. Thank you.
So people who get worried that doing an endoscope, I'm not able to do him, I have to put a speculum, I have to take a C-arm, but that's all part of the learning process. So when I showed my video yesterday of 2005, I had speculum inside and I used to use the C-arm to know the direction. There's nothing wrong in it, absolutely nothing wrong in that. But you have to evolve over time, that's fine. So nothing wrong in that I could not do it, I had to take the microscope, absolutely fine. It is one more step of learning and you will learn better in this, always. Anybody else wants to give any comments, experts, faculty, Dandapani, Avdesh?
Yeah, first of all, I would like to thank him for putting in such a big show. And I was very much glad that he put a detailed kind of so many lectures over the week. And his motive was very clear, that I wanted to, he was telling that I wanted to sensitize the delegates who are coming, so that they will be primed before they come, so that it will be easy for them to understand whatever is being demonstrated. So that is very nice. I think this is the first time I think any cadaveric workshop had this kind of concept of having 1 week. So I think he has to be applauded. See, doing a one-day program itself is a big challenge nowadays. And despite having a 2-day cadaveric workshop, he managed to pull up a kind of a long program in the week. And more than that, attendance was so good. Even NSI webinars which we are doing, attendance is gradually kind of dropping. But he was telling more than 70 people had attended some sessions. Yeah, that's a kind of, that is amazing. And having a live attendance of so many people. So, because he was putting in so much work, we could see. And I think definitely because Dr. Subodh has been behind him like a kind of pillar of strength. So he is always kind of, so I think the whole team need to be kind of applauded for putting in a fantastic show. Of course, I think they must have faced lots of challenges, but kind of they will tell us later. But I think the show was fantastic. I think all of us need to give a kind of round of applause for both of them.
As a personal thing, I mean, you always feel proud when your student does well. Ramesh was one of my student, one of the brightest student from this place only. And he's doing well, his work is doing well, and he has forayed into this workshop and these things. He thought of it, conceptualized it, implemented it in a very nice way. I think that's a great job done.
And the idea also come from you only, sir, that you should not enter the OT without reading. You should not enter if you don't answer. So that's how even if you come into cadaver, then you should read and come. That's how it started. Thank you.
So you can continue the dissection. In between, anybody wants to have a lunch, can have lunch and come back again. The cadaver hall, everything will be there till 5:30. Okay. At your leisure, according to your departure time, you can spend time, you can dissect it. Okay. But one thing I told everyone, respect the cadavers, clean the area before you leave. And don't use the drill without supervision. Thank you.
Thank you all. Thank you. Please join for the, whoever wants to dissect, and some other people can join for lunch.